start our session. Over to you, sir.
Okay. Good evening to all of you. I should say a special good morning to Dr. Barbosa, who is joining us from Brazil. So happy and good Ganesh Chaturthi wishes to everyone. Ganesh Chaturthi Day is actually a traditional day where we think that we pray God that all good things come, good health, happiness, peace and joy, and all bad things should leave us. And so probably this is a day which all of us will be united to pray that we all get out of the clutches of COVID. COVID has actually locked us all down, but there are many new normals that have been created. And one of that is the positive effect and the ability of all of us to connect internationally and frequently across the world for academic purposes by these webinars. So as you know, we at Ganga Hospital, we are always proud of the 4 foundations of the hospital: clinical excellence, academics, research, and giving back to society. Even in the peak of the COVID, we had not cut down on the clinical, our work. And also we felt that we should maintain the same level of academic activities that we have always stood for. So I thank Dr. Dhansekhar for coordinating this whole event. And this will be a regular feature where we have a Ganga Hospital webinar, a teaching program, bringing a lot of the faculty from the hospital, but also bringing the best from across the world. And we will talk about different topics. So today we have, for a start, Ganesh Chaturthi is a very good day to have an auspicious start. And we are also starting with a very interesting topic on proximal femoral fractures, a region of interest to everyone, and a region which can pose fractures which can challenge even the best of the surgeons at any period of time. And for this, we have a galaxy of speakers from the institution. We have Dr. Dina Dayalan, whom all of you know, one of the star and most prominent trauma surgeons of the country. We have Dr. Ramesh Perumal, who has a special interest in pelviacetabular fractures and proximal femurs. We have Dr. Devendra, one of the senior trauma consultants of Ganga Hospital, Dr. Vel Murugesan, Dr. Zakaria, and Dr. Arun Kamal, all associate trauma consultants who have vast experience, who on a day-to-day manage such complex fractures. And to add cream to the cake, we have none other than Professor Paulo Barbosa from Brazil. As you all know that he is one of the persons who have contributed a lot to fracture care, especially to fractures of this region. And he's going to talk to us on reasons to choose TFN over PFN in trochanteric fractures. He has played a huge role on the design and promotion of TFN, and it will be really nice to hear from him, from the horse's mouth, if I can say, on why TFN is better than PFN. So I have no doubts that the following 1 hour will be rich in academics, and we will go straight on. After thanking all the faculty members, I would call upon Dr. Ramesh to talk on this very interesting topic, femoral head fractures, what decides your approach? Over to you, Ramesh.
Thank you, sir. So can you able to see my screen, sir? Is
Yes,
my
sir.
voice is audible?
Yes, sir, you are completely audible and visible. You can continue.
So thank you very much. Femoral head fractures. Let me share Ganga experience.
Ramesh, go on to slideshow.
Is my slides are visible, sir?
Sir, not yet. Just stop your screen sharing and share once again.
Is it fine now?
Yeah, sir, perfect.
Yeah. So femoral head fractures, let me share the Ganga experience of this unique fractures, which is rare, but often it needs a good amount of algorithmic care for an uneventful outcome. So here you can see a 24-year-old man who had a road traffic accident. You can see there is a posterior dislocation of hip and a suspected femoral head fracture. You all agree that it needs an emergency close reduction. So he underwent a close reduction. You can see the hip joint is congruent. However, there is an infrafoveal femoral head fracture seen on the X-ray. So all of you will accept it needs a CT scan and look for the extent of the femoral head and also the location of the fragment and presence of an intra-articular loose bodies and the congruency of the hip. Here, CT scan is showing a small infrafoveal fragment which is comminuted and it's minimally displaced. So in this consensus, so we are worried about whether this can be treated conservatively because the hip is congruent. And if at all, if you want to approach the infrafoveal femoral head, we need an anterior approach or the posterior approach. Since the hip is dislocated posteriorly, there is a rent in the capsule. So it can be approached posteriorly or it can go an anterior approach where the fragment is infrafoveal. When you approach the fragment, it can be amenable for fixation or you can excise the fragment. When you excise the fragment, there is a consensus where the hip will dislocate because the volume of head is being removed from the native hip joint. So these are all the questions will come into the mind. So the importance of these fractures depends upon the blood shape of the femoral head. Here you can see the main blood supply is from the medial circumflex femoral artery, which supplies the posterior and infrafoveal part of the femoral head, and the larger dome is supplied by sharing both the medial and the lateral circumflex femoral vessels. The ligamentum peris vessel constitute only a smaller portion of the fovea. So the Pipkin has classified in 1957 in these fractures, a type 1 being infrafoveal and type 2 being a suprafoveal. A part forms the weight-bearing dome of the hip joint, and type 3 is the one which has got an associated femoral neck fracture. In type 4, it is associated with the acetabular rim injuries. It may be type 1 or type 2. So the guidelines of this management evolved over a period of time from conservative approach and approaching the fragment from the anterior side using a Smith-Peterson approach or a modified Hutter approach, or the posterior Cocker-Langenbach approach, where most of these are associated with the posterior dislocations by using a Cocker-Langenbach familiar approach, where the rent can be used to access the femoral head for reduction and fixation. When there is an associated acetabular rim injuries, the posterior approach, we can add a trochanteric flip osteotomy where you can access both the superior dome of the acetabulum and also the femoral head can be approached. And the GONS has got the universal advantage of safe dislocation of the surgical dislocation and also addressing the femoral head as well as the acetabular injuries. So when come to type 1, so the consensus are whether infrafoveal fragment can be treated conservatively or fixation or excision. So here, following an example of infrafoveal femoral head fracture, following a dislocation, the infrafoveal fragment is congruent and the reduction is satisfactory. Hence, following a close reduction, when the infrafoveal fragment reduction is congruent, the hip can be treated conservatively and the functional outcome can be better. So this is one way where there is a posterior dislocation where the Cocker-Langenbach approach can be used. So the rent in the capsule can be addressed to remove the fragment or address the fragment, and the joint can be dislocated and fixation can be done. This is one other approach where you can use the rent in the capsule in the posterior approaches. In other things where you can do an indirect reduction following a close reduction of the femoral head fracture dislocation, when the big fragment, a non-comminuted, undisplaced fracture following a dislocation, by doing a posterior approach using a Cocker-Langenbach, the joint need not be dislocated, but only you can spare the rest of rotators except you can release the piriformis, and the rent in the capsule can be a little bit extended, and using an indirect reduction too, where you can use the Herbert screws or the bioabsorbable screws, you can fix the femoral head fragment, which can lead to uneventful outcome. This is one other example where the infrafoveal fragment was approached but it was found to be comminuted and it is in multiple pieces. Hence, to avoid the intra-articular extension of the loose bodies, the fragments were removed. So there are biomechanical studies that have shown that the small comminuted infrafoveal fragments can be removed without causing an instability in the hip joint. Here is an example of a posterior dislocation with an infrafoveal fragment. Following a close reduction, you can see the infrafoveal fragment is rotated to 180 degrees. So these are all the ones which needs an open reduction and anatomical reduction. In these cases, with the posterior acetabular, maybe a minimal rim injuries with an infrafoveal fragment. So we can use a Gaunt's approach where you can flip the trochanter, and also without releasing the short external rotators, the hip can be dislocated and the femoral head fragment can be fixed with the Herbert screws, and further the osteotomy was fixed with the 4.5 cortical screws. The hip joint is functional at 5 years follow-up. Patient had an uneventful outcome without any evidence of avascular necrosis or post-traumatic arthrosis in the affected hip. This is an example of a 23-year-old male who had an Pipkin type 2. We can see the suprafoveal fragment is displaced anteriorly and inferiorly, and there is a posterior dislocation of the hip joint. Where you can see the CT scans, there is a further extension of the comminution in the antero-inferior part of the head also. So these also underwent through a Gaunt's approach following a trochanteric flip, where both the fragments were identified and fixation with Herbert screws was done. Since it is a weight-bearing zone and comminuted fragments, at the end of 2 years follow-up, we can see there is an evidence of avascular necrosis in the dome part, but patient was reasonably doing well at 2 years follow-up. Even at 4 years follow-up, there is an evidence of avascular necrosis, but patient is still functionally active and able to manage all his activities. However, in a long run, if he becomes symptomatic, he will be justified with a total hip replacement at a later stage. This is an example of a type 3 Pipkin where you can see a ipsilateral femoral head with a neck fracture and an associated posterior wall and column fracture with an ipsilateral shaft of femur. The 67-year-old male who also had a right side supracondylar femur fracture, and he had a chest injury and also shoulder dislocation. So these are all a part of polytrauma injuries. However, this neck of femur, a 67-year-old man, usually is justified for a total hip replacement. But the presence of other injuries like an acetabular injury, ipsilateral shaft of femur, and also the other injuries, salvage options like fixation can be attempted. Here, in these patients of complex floating hip injury, we did a same Gaunt's approach where the head was retrieved and the posterior wall and column was fixed with the similar approach. Same acetabulum was fixed and followed by the femoral neck was inserted and provisional K-wire fixation was done. Once the acetabulum fixation femoral neck was done, we started the piriform entry for the nailing was done. Here you can see the reaming of the canal, and we use a reconstruction nail, and the reconstruction screws were held to fix the femoral neck also. The trochanter wiring was done following the flip, and at the end of fixation you can see the femoral neck reduction was anatomical. So post the reduction exercise showing both the acetabulum and the congruency of the joint and the femoral neck reduction and the shaft of femur was found to be satisfactory. However, we all know that the 67-year-old male with the femoral impacted head and the neck of femur, most of them go for avascular necrosis. Patient has been explained about. Patient will need one more surgery in the form of a total hip replacement. Once is functionally all right, following healing all the other fractures, the other side supracondylar fractures and chest injury, once the patient general condition is improved, patient has been explained about the option of total hip replacement. So at the end of 1 year, it has gone for an avascular necrosis. He underwent a total hip replacement, but with a special cage construct was done. This is one of our case series published in the literature. And this is another one of Pipkin type 4. In a 64-year-old male, we can see a transverse posterior wall fracture of the acetabulum with an infrafoveal femoral head fractures. So the predominant injury was a transverse posterior wall fragment of the acetabulum associated with the femoral head fracture. Here we did a similar one of the posterior Cocker-Langenbach, which trochanteric flip was done. Rotators were isolated and they were being incised and retracted. And the same similar trochanteric flip was done, and the femoral head was found to be a little larger, more than 40%. So it was fixed with the Herbert screws. And once the hip was reduced, we used the Ferbuff clamp for reducing the posterior column fracture. And further, the posterior wall was fixed with the mini screws. Further, it was buttressed with the reconstruction plate. We can see the post-reduction X-ray, the joint was congruent and the femoral head is in a good place and the osteotomy was fixed with a 4.5 cortical screws with an uneventful outcome. However, in a comminuted femoral head fracture in a 47-year-old male, CT shows the comminuted fragments, and these are amenable for a primary total hip replacement is justified in these patients. In our experience for the past 5 years, we have treated 35 femoral head fractures. You can see most of them are belong to type 1 and type 2 of 24 cases, and type 3 and 4 are 5 and 6. These are our management in all these injuries. You can see the type 1, the 11 cases, the outcome is good following a fixation, excision, or the conservative treatment following a congruent hit. But in type 2, 5 of them required a total hip replacement because of involvement of the congruency of the joint, later presence of avascular necrosis and arthritis. In type 3, since the presence of comminuted femoral neck associated with the femoral head fracture, the chance of AV is high. So most of them required a total hip replacement at long-term follow-up. And in type 4 injuries, where the acetabular fracture forms a predominant injury, where good outcome is possible if the reconstruction is done better. So the complications in the literature are much comparable with our experience of in the incidence of avascular necrosis, arthritis, and nerve injury, and also the heterotopic ossifications. To conclude, congruency of the hip should be the primary goal in these injuries. However, primary arthroplasty situations, special situations like elderly patients, comminuted neck of femur, and type 1 always has a very good outcome following any method of treatment, and type 2 and 3 are more prone for AV and arthritis since it has been explained in detail to the patients and the attenders. Both the anterior and posterior approach are comparable in the outcome. There's a lot of meta-analysis showing the outcome is good in either approaches. Gaunt's approach has got a universal advantage of approaching the femoral head, acetabular rim, and also the capsular repair. So thank you very much for your patient listening.
Ramesh,
Yes, sir.
thank you. So what, suppose in a case, say for example, it is type 2, how do you decide between Gaunt's osteotomy and then other approaches?
So the common thing are the Hutter approach and the posterior Cocker-Langenbeck and the Gaunt's approach. The Gaunt's approach, the advantages are visualization of the femoral head is better, and you can also address the capsular repair also. So most of my experience, we fix the femoral, we can have a 360-degree orientation of the femoral head so that the fixation is better, more visualization can be done for the femoral head, and also the capsule can be repaired in the same situations. When the anterior approach, because there is a dislocation in the posterior side, you're opening on the anterior side, visualization is better, but the posterior capsule can't be repaired.
Although you have any questions or anything to add for these femoral head fractures?
That was exactly what you asked, because sometimes we tend to go from the interior, but the posterior, as Ramesh said, is a 360 degrees view. The only indication that we go really anterior when the fragment is manageable by the anterior part of the head is the major fragment, then we go anterior. I don't think that the fracture is already disrupted. We can do nothing about it, but going anterior, that is not vascular violation for the joint. But it was great presentation and huge experience in a case that is not common.
Thank you, sir.
Ramesh, suppose if there is, you said that total hip replacement is a good option in a neck with head fracture.
Yes.
Is it, suppose if you try to fix it, say you want to go ahead and fix it, somebody in the periphery wants to fix it, what will be the approach they have to choose?
So in the femoral neck with the femoral head, so my approach should be doing
I think
Gaunt's osteotomy.
Devendra has to mute it, or
So my approach would be to do a trochanteric. The Gons is a safer one, sir, because the infrafoveal fragment cannot be visualized in a Cocker-Langenbeck approach clearly. With the presence of a femoral neck fracture, there may be difficulty in visualization. You might be manipulating the femoral neck a lot. So when you're doing a Gons flip osteotomy, where your femoral head will be seen in a better way, so the provisionally you can fix the femoral neck, and then further you can dislocate the hip, and the femoral head can be fixed. So the violation is minimal in a case of Gons procedure. So doing a Gons and fixing the femoral neck, further you can dislocate the hip joint, identify the femoral head fragment. Most of the femoral neck with the femoral head are infrafoveal. So the fragment is well visualized in a case of surgical dislocations.
Dhanshekar is also with us today. Dhanshekar, are you online?
Yes, sir. Yes, sir.
Because see, like when they are doing a primary total hip review, say for example, the example I asked, like neck with femoral head fracture.
Yes, sir.
Is it, suppose it is like a virgin joint for you to operate, isn't it? Like a primary total hip.
Yes.
It can be easily be done. So compared to that, if there is AVN and then if they come very late, what is the difficulties you face between the two?
So any previous surgeries, there is a high risk of infection, sir. So there is a small risk of, not high risk, you can say a small risk of infection. There's a previous implant. Always there is a worry that there could be mild low-grade infection. That is one worry. And doing in an acute situation is slightly difficult compared to a patient with secondary arthritis. Because the soft tissues are lax, patient can have acute dislocation with the head with neck fracture. So managing the soft tissues, we now go for a dual mobility type of the processes where we use a large head to prevent dislocation. When the patient comes with secondary arthritis, we need to rule out infection first. Always we remove the implant, then go for a second stage, or if there is no obvious infection intra, we go ahead with the primary surgery. Only thing is the surgery, soft tissues are well healed and the outcome of joint replacement is very good. You need to always be careful about infection.
Yeah. Any issues to be discussed? Otherwise, we can go on to the next topic. So, Paulo, you have anything to add or anything to tell us?
Yes, I would love to hear from you guys, because I know you have a huge experience on massive trauma, and your hospital is 24/7 with highly trained surgeons. Have you ever thought on, instead of reduce the dislocation, take a CT, evaluate the head, and then do the surgery for fixation? Have you ever considered, instead of reduce, just go to the OR with the hip dislocated, proceed for immediate fixation at the emergency attendant to decrease the number of goes in and out from the acetabulum and get a better vascularization right after the trauma?
No, it is a food for thought, because our routine practice, we have been reducing and taking a CT scan. So we have never thought about just to take a CT and then evaluate and then go ahead for this thing, because this is something that we can definitely work on, because we have never thought the other way. We want to, we have made a protocol that we'll first reduce it, see the position of the fragment, and then take a CT, then only we decide. So I think this is food for thought for us, and then we can really look into this.
But I would like to differ, because if it's a type 1 fracture and patient, we go in and reduce, and post-op CT shows good congruent reduction, there are no intra-articular loose fragments. We have managed many times conservatively. So you're going to operate on too many patients and we're doing unnecessary surgery.
No.
So type 1, we can.
Type 1 is something we have to reduce, because we know that it can be congruently reduced. So it will be like the type 2 version. We have to think on those lines.
Yes.
When we see that the fragment is out anyway, it won't go inside the joint with closed maneuver. So we reduce and then we go back, dislocate again. That could be something to improve the AVN rates and the long-term follow-up. But it needs experience, need a hospital with a high volume to get experienced surgeons doing that in the middle of the night.
Thank you. So we'll move on to the next topic.
Sir, are you able to see my screen?
Yeah.
Yeah. So, comminuted neck of femur fractures in young patients is a difficult problem, and I'm going to talk on decision making in this tough situation to yield a good outcome. These fractured neck of femurs mainly occur following an external rotation injury. This results in a tension failure on the anterior cortex and a compressive failure on the posterior cortex, resulting in comminution of the posterior cortex. 70% of Powell's type 3 fractures are associated with posteromedial comminution. In the presence of this posteromedial comminution, there is increased incidence of non-union, AVN, shortening, and increased rate of revision surgeries. A comminution is said to be significant when more than 25% of posterior surface area is involved. When the comminution is present only in the posterior aspect, with reduction, we will be able to maintain the anterior cortical continuity. So this will help us maintain the neck length. But when the comminution is present both anterior and posterior, maintaining the neck length would be very difficult. Excessive collapse can occur and result in neck length shortening. When we see here, though there is a significant bone loss and comminution in the posterior aspect, we were able to get an intact anterior cortex in line. This will help us maintain the neck length. However, when there is a fracture of both anterior and posterior cortex, as in this picture, maintaining a neck length would be a great challenge. So all displaced neck of femur fractures, we do a traction internal rotation view to assess the Powell's angle and presence of comminution. In the presence of comminution, we do a CT scan to assess the extent and location of the comminution. Here we have a displaced fractured neck of femur in a young adult with the insignificant comminution, that is less than 25% of the surface area, and a Powell's angle of 45 degrees. We have treated him with multiple parallel cancellous screws in an inverted triangle fashion. The preferred pattern is an inverted triangle pattern with the screws within 3 mm from the periphery. In case of posterior comminution, we can increase the stability by adding a fourth screw, which will increase the area of fixation both in the head and neck. This is a similar fracture with the insignificant comminution. However, the Powell's angle is more vertical. Here we have a Powell's angle of 70 degrees. In Powell's type 3 fracture, we prefer to use a angle stable sliding device. In this case, we have used a DHS with derotation screw to yield a good outcome. When we find that there is a significant comminution of posterior cortex, however, the anterior cortex is relatively intact with no comminution or minimal comminution, and Powell's angle is less than 50 degrees, we will be able to maintain the anterior cortex. The main problem here is not maintaining the neck length, but the defect in the posterior side, which can be addressed by doing an impaction bone grafting and DHS derotation screw fixation. First step is to reduce the femoral neck fracture and secure it with K wires, followed by doing a DHS fixation. We have to first put a DHS guide wire and start dreaming with the triple dreamer. Through the tract formed by the triple dreamer, we can pack the martialized iliac cleft grafts into the comminuted site or the fracture site. And this can be followed by DHS screw fixation. So we have published our technique of impaction bone grafting in treatment of neck of femur non-unions in Journal of Orthopaedic Trauma in 2019. In this case, though the patient had a significant posterior defect, we were able to achieve union and with DHS as an impaction bone grafting without much loss in neck length. Similar patient with a significant posterior comminution and an intact, relatively less comminuted anterior cortex, but a high Powell's angle. Whenever the Powell's angle is more vertical, it is important to convert the shearing force into a compressive force by doing a valgus osteotomy and changing the fracture, making the fracture line more horizontal. So the primary valgus osteotomy is done in this patient along with DHS and derotation screw fixation. So this fracture went on to unite both in the osteotomy site and in the fracture site, and patient had a relatively good functional outcome. However, there was a minimal valgus deformity at the knee joint. Mago et al. Had published its results of primary intertrochanteric osteotomy following intracapsular neck of femur fractures with the union rate of 94% and avian rate of 8%. When we find combination of both anterior and posterior cortex, we use a fibula stud graft to maintain the neck length. Use of fibula stud graft has already been described in literature for femoral neck fractures with significant posterior combination. And here also we first reduce the fracture and secure it with temporarily with stem and pins, followed by DHS and impaction bone grafting. Once DHS fixation is done, we pass a guide wire parallel and superior to the DHS screw. And we use the first reamer of the inner reamer of the triple reamer set to create a pilot hole for the fibula to be passed. Fibula is either harvested from ipsilateral leg or fibular allograft can be used. The harvested fibula is shaped to the hole and it is impacted across the fracture site through the hole. Once it is across the fracture site, the excessive fibula can be shaved off from the trochanteric end, flush to the trochanter. Though the patient had significant combination of posterior and anterior cortex, we were able to maintain the neck length and fracture went on to unite. So in conclusion, if there is not a significant combination, we look at Powell's angle. If it is less than 50 degrees, we use multiple cancellous screws in an inverted triangle fashion. If it is more than 50 degrees, we use an angle stable sliding device, mostly DHS and a D-rotation screw fixation. When we find a combination which is significant, that is more than 25% of posterior surface area, we see where the combination is present, whether it is only posterior. If it is only posterior and Powell's angle is less than 50 degrees, we use impaction bone grafting and DHS fixation. If the fracture line is more vertical, then we convert it shearing force to compressive force by doing a primary valgus osteotomy and DHS fixation. In case of fractures where there is both anterior and posterior combination, we use fibula stud graft to maintain the neck length. In all cases of significant combination, we do impaction bone grafting irrespective of the method of fixation. So this is our treatment algorithm in treatment of neck of femur fractures with significant combination. Thank you.
Sir, you have to unmute yourself, sir. Did he, sir?
Well, you have made it very simple and then made it very lucid presentation. And we take some opinion from Paulo, because there are a lot of methods of management that is being described. So we wanted to give a nice algorithm for usage of all these techniques. That is the basis of this presentation. And basically, I wanted the opinion from Paulo as well on this presentation. So
There was a great presentation, and I really like when I see this algorithm and then all this protocols, because it just tells us people think about what they're going to do and what they look. The reduction, I think it's the main issue in every single fracture, and the femoral neck fracture is not different. From my side, I'm using a little bit different from you guys, because I don't use the DHS anymore even for those comminuted fractures. I use the telescoping implants. It's a plate, it's a lateral plate with 4 mini DHS connected.
Yeah, that is the FNS system, you mean?
No, it's not. It's from Stryker Zimmer and Esculap. They have it. It's a lateral plate, yeah, connected with, it's like 4 DHS, because it removes less bone and gives the screw fixation advantages and the telescoping advantage in one implant. And another thing, when I use cannulated screw, instead of doing the valgus osteotomy, we use the Powers screw that goes from the greater trochanter to the calcar, as trying to be less invasive on the valgus osteotomy. On the other side, for all complications in non-union, the valgus osteotomy is the first choice. But as he said, reduction is everything. Look for the comminution on the posterior aspect of the neck of the femur. The question that I have for him is that when you look for the literature nowadays, everybody's talking about putting a plate as a method of reduction and fixation. I would like to hear your opinion, because you didn't mention this plate anterior-inferior. I have my opinion, but I would like to hear from you, Vermeusen.
You're asking about the buttress plates.
Yeah.
So most of our reductions, we do it closed. Most of the time, it very less than 2% of our patients we have done open reduction, and we feel that some amount of collapse is needed for the fracture to unite, right? And so putting a buttress plate will be more invasive also. So we don't have much experience on opening and putting a buttress plate on the calcar aspect.
That is so. This is amazing, because on the last year course on femoral neck fracture in Davos, there was a few surgeons' opinions that it's impossible to reduce close a femoral neck fracture.
Lot of people argue on this.
All of them.
Yeah, a lot of people argue and say that closed cannot be, but they have to come and believe us, because they have to see us to believe, because we have not done many open reduction at all. All our fixations are closed methods of reduction. We wonder how these people are doing only open, because probably they have very less threshold to open straight away, go and open it and then reduce it and fix it. So
it can be a very low threshold, but looking for your presentation, I think that they have high threshold for operation. So they are operating more than they should. And in my practice, I'm not as good as you guys are, but I don't open more than 10% of the cases. And this plate, I think that is very difficult to use. You need a lot of external rotation, you need a lot of dissection. And I've seen a lot of complications with this plate because they rely on the plate and they forgot the reduction. So that I'm not using that anymore.
It looks very attractive on the X-rays, but I'm sure it is going to be very difficult, and then any revision that comes up will be extremely tough.
Yep.
So Dhanshekar, any questions are coming up?
I'll just check the link, sir.
Yeah. As you keep checking the link, you let us know, and then we'll go on to the next presentation and see. Okay?
Okay.
You can take the questions in the next after that.
There is a question. What is the role of MRI in detecting early avian after fracture neck of femur?
Sir, we don't routinely, before surgery preoperatively, we don't routinely do an MRI because it will not change our, to see the vascularity of the femoral head. We do not, because it is not going to change our treatment, what we are going to do in these young patients. And if you have to do an MRI post-operatively, I think 6 months is, it has been, literature says that 6 months is the ideal time to do an MRI, which has a higher sensitivity and specificity in detecting AVN following fixation.
So there's a question from Vishal Agarwal.
No, like before this thing, yes. When there is a femoral head in a fresh situation, all of them definitely requires fixation. So there is no need to go ahead and ask and see what is the role of AVN in this. Whereas in a non-union scenario, yes, you have to look for AVN. So many times you can take an MRI, but MRI also, like, interpretation must be good. There are studies which said that radioisotope scanning can be done, so which can tell you whether it is vascular or not. But what has been proved right is, like, intraoperatively, if there is a bleeding from the femoral head, that is what it means as a vascular head. So that is the intraoperative test that can help you in detecting the vascularity. Paulo, any opinion on this vascularity of the femoral head?
I'm with you, Didi. It's a fracture. We need to fix it. And I'm really, in young patients, there's no question we need to fix. A few years ago, I revised one paper from China, and they did up to 5 days the microangiography and MRI. And they could prove that the head was vascularized up to 5 days. So we can't do a study like this because we can't just wait 5 days just to prove that the head is viable. So I don't use MRI for this one. I think we need to push the limits on the young patients, and I fix it. And bleeding sign it's okay, but young patient, we need to fix it.
So there's one more question. It is from Vishal Agarwal from Farrukhabad. Neglected fracture neck of femur in young adult. What is the treatment?
Yeah, we are going to take it up in the next webinar as well. So the neglected fractures. But however, in a neglected fracture in a young adult, it will be like you will have to definitely go in, and depending upon what has happened, see, like it can be in varus, it can be avian, all those things you will have to look at it. You need to correct the varus positioning, as well as you'll have to go ahead and do the fixation with the DHS, and also an allograft fibula you can use. And also, like when we are using the DHS, we routinely use an impaction bone grafting. We have used the impaction bone grafting in all neglected fractures, and we have got a very good result. That is, we have presented also and we have published also. It is almost 97% we could get a good result. So
Thank you, sir. Thank you.
Anything, any other questions?
There are further questions on next topics, sir. So we'll go ahead with the next presentation.
Okay. Okay.
There are a lot of questions coming. When the topic comes, we'll discuss the.
Yeah. Zakaria, no, next.
Yes, sir. Sir, am I audible, sir?
Yes.
Yes, sir.
Be louder.
So is my presentation clear, sir?
You have to share your presentation.
Sir, to share your screen, at below side of the screen, there is one share screen icon. From that, you will be able to share your screen.
Share screen, yeah.
Yeah, so now just select your presentation and then click on share button again.
Nanshekar, as he is sharing, any other questions are there, means? Yeah.
It's okay, sir?
Yes. Be louder.
Yes, sir. So thank you, sir. So today I'll be talking about an interesting topic, nailing tips and tricks in trochanteric fracture, in unstable trochanteric fractures. So trochanteric fractures are bread and butter to the trauma surgeons. They present to us with a wide range of different difficult fracture pattern. And these fracture ranges from undisplaced simple trochanters to fragility fractures in elders and severely displaced multitrochanteric fractures in young adults, which are usually associated with an RTA. So, in 1949, Evans classified trochanteric fracture into stable and unstable fracture pattern based on the post-medial continuity. So ever since this classification, there comes many classification has been established, and all this classification helps us to understand the fracture pattern better and guides us when providing the best possible fixation. Stay right, compare.
What is the problem, Zakaria?
Sir, is my volume audible, sir?
Yeah, sir, your audio is clear, sir.
Your voice is breaking, but your slide is gone.
Now it's clear, sir?
Yeah, now it's clear. The slide, you need to share your slide.
Now share the screen again and go back.
So now it's okay, sir?
Sir, you have to share your screen once again. The same step you have to follow, sir. Just sir, open the Zoom app and click on share screen button. सर अभी आपको स्क्रीन पे क्या दिख रहा है, आप बता सकते हैं मुझे?
सर मेरे को ब्लू कलर स्क्रीन दिख रहा है।
ओके, वो एस्केप कर दीजिए, मे बी आप अपने प्रेजेंटेशन में है सर, वो एस्केप कर दीजिए, देन जूम ऐप ओपन कीजिए फिर से।
सर अनस्टेबल फ्रैक्चर पैटर्न आपको ये स्क्रीन दिख रहा है?
नहीं सर, हमें स्क्रीन नहीं दिख रही है, आपकी स्क्रीन स्टॉप हो गई है।
अच्छा।
आप जस्ट फुल स्क्रीन मोड पे होगे, आप वो फुल स्क्रीन मोड से एस्केप हो जाइए।
प्रेस एस्केप ज़करिया।
यस सर। सर नाउ सर?
सर अभी जूम ऐप ओपन कीजिए, उसमें से शेयर स्क्रीन कीजिए फिर से।
Are you able to open Zoom app?
अब दिख रहा सर अभी?
सर अभी भी नहीं दिख रहा। सर आप जूम ऐप ओपन कर पा रहे हैं क्या अभी? या अभी स्टार्ट हो रहा है सर, या इट इज विजिबल। सर अगेन इट हैज स्टॉप।
Dhanashekar.
Yes, sir.
Dhanashekar, we can go to Paulo's talk and then come back to Zacharias if there is an issue with that.
Okay. Yes.
Dhanashekar? Dhanashekar?
Yes, sir.
So we'll go on to Paulo's talk and then come back to Zacharias. We can change the order.
The Professor Paulo's Professor, can you share your screen and you can present the topic on reasons to choose between TFN or PFN.
Can you see my screen?
Yes. Yeah.
Yes, sir.
Great. Good morning to all of you. Thank you very much, my friend Didi and the friends from the Ganga Hospital, for this invitation to be here. And it's a great pleasure. Virtually present, but my heart is in India, as you know. So Didi asked me to talk about the reasons to choose the TFNA over the PFNA in trochanteric or subtrochanteric fractures. And I'm going to tell you a story about why we came to the TFNA. And looking for this guy here, he said that doing the same thing over and over again and expecting different results is the definition of insanity. And this is not what we do on trauma surgery. When we look for the portfolio since the first PFN to the TFNA today, they are not new implant after the other. I rather say that they are an evolution. They are the evolution just like the wheel. The same wheel and the ones that we have today, they do the same function. But I prefer to run my car with this wheel here and not the first one. It was an evolution. Everything started with the first nails against the DHS. They both had a single head element. The DHS was extra, and the benefits of the intramedular from the nail. The lever arm was smaller for the nail, that proved to be a better thing. the extramedullary implant is a load-bearing, and the IM nail is a load-sharing device that proves biologically and biomechanically to be better for the fracture healing. And this was the first one that was widely used all over the world, was the Gamma nail. But as soon as we started to use it, a lot of complications came out that almost put the nail in the garbage. A lot of cutout, and especially femur fracture below the tip of the nail, as you can see. So when we look at this, instead of putting to the garbage, remember Einstein. We need to look for the papers. We need to look what was reported and think about it. And based on the complications of the Gamma nail, we could advise that the screw had a very, very large diameter. There was a short distance between the last one and the tip of the nail, and that was a poor head element fixation. So based on this one, on all of these findings published at the literature, and the recognition that is not only the forces on the lateral side and the medial side, but there was also a rotational instability around the head element that contributed to the poor head element fixation. This guy used to be a very famous American football head coach. And he said that when you make a mistake, there are only 3 things you should ever do about it: admit, learn from it, and don't repeat it. And that's what us, the trauma guys that think about how to improve techniques, came with the PFN, the first generation of the PFN. Instead of one lag screw, they had dual lag screw fixation, exactly to get a better rotational control of the head element. Based on the failure, they tried to decrease the diameter of the proximal part of the nail to remove less bone. The nail, even the short nail, has a longer version to get a transition from the implant to the bone is smoothly different from the sharp, subtle transmission of the force at the Gamma nail. The distal screw had a small diameter comparing with the first generation Gamma nail, and they increased the distance between the last screw and the tip of the nail to get a more elastic fixation of the tip and decrease the number of distal tip femur fracture. And they also decreased the diameter of the tip of the nail. So learning with the problems, they created a new nail. And that was a very nice example. At that time, A3 fractures were the must to fix with the nail. Here's the PFN, very nice healing, good reduction, and the CCD angle restored. Everybody in the market follow the dual axis fixation based on the early success of the PFN. But there is always a but. We had a screw cut out, smaller than the Gamma nail. We had less shaft fracture, and we had a better function with this kind of implant. But we came with something new. We bring some solution, we bring together some problems. And this was the huge problem with the dual axe femoral head element fixation, the Z effect or the reverse Z effect. This is the Z effect, and this is the reverse Z effect when the big one goes into the joint. It was a huge problem, a lot of publishing in the literature that killed most of the implants with the dual axe fixation. So that was a huge change at that time at the nail group of the AO. And instead of the dual head fixation, they came back for the single head element fixation, but with the blade. They also decreased the proximal nail of the diameter because of the better titanium alloy to remove less bone and protect the bone. They had a shorter proximal tip. There was a lot of complaint about the big tip of the nail outside the greater trochanter, especially in the smaller population. The single screw instead of 2 screws, but the single screw could be static or dynamic depending on the angulation of the aiming device. So this was the TFN and the PFN A presented. This one in America, Europe, and in South America. This was Europe and Asia from the same company. The spiral blade at that time was the must, the hot topic, because comparing to the screw, the blade removed less bone, and it's not based on fixation, it is based on impaction. That's why we save bone and we get a better grip between the blade and the bone. When we did this study comparing the DHS, DHHS, the PFN, and the gamma nail, the cutout with the blade was less than all four together. So the spiral blade has a better fixation, protects the bone from the cutout and the varus fixation. All the studies, how many cycles do we need to cut out? TFN was better than all others. The varus collapse, the TFN was better than all others. And the rotation around the implant was even better than the PFN. A single axis fixation of the femoral head was better than the dual fixation from the PFN. Why? The blade holding the bone together with impaction was much better to control rotation. Again, another A3 fracture treated with the reduction using the collinear clamp on this A3 fracture. No problems with the collinear clamp and the aiming device. That is the final of very nice CCD angle restoration, and 1 year fracture healed blade was a good thing. At that time, I was published comparing the PFNA and the DHS, and was faster. The patient with the PFNA walks faster than the DHS, and the complications were equal to the DHS and mainly related with the tip apex distance that was not followed as Baumgartner published. But, as I used to say, there's always a but. We come with one solution, nature brings another problem. And the problem with the blade was the cut through. We provided a better fixation for the cutout, but instead of cutting up, it started to cut through the joint. There was a problem more common with the blade than with the screw. So based with this one and this publication by Cochrane in 2014, that the operation of 6.3% of the cases with the nail. This is a huge number. So we had to stop and think, do we need a new nail? Yes, but what do we need in a new nail? So we need to understand where is the problem. It's just not getting everything else and don't solve the problems, and then we need another new nail. So we analyzed the most frequent complication published on the literature. That was the perforation of the anterior femur cortex, anterior thigh pain, especially with the short nail, cut out and cut through, being 8% of the cases, and implant failure, 5%. So these two plus perforation had an important problem that needed solution. So during this, whoops. Can you guys see my screen?
We are seeing your screen, yes.
Okay, good. So we had the problem, now we need the solution. And the solution, we did a lot of studies at the NAO group through the AO, and we came with the TFNA rationale. What do we need to give for the surgeons on this new implant? And had 3 pillars. It needs to have a good design based on the outcomes, based on what was published in literature and didn't work. We need to do something better for the surgeon to make his life at the OR easier, not complex. And we need to give them options on different patients because they are not all the same. So everything was based on clinical needs. and which clinical needs we could find out. Fixation and poor bone quality is still a huge problem. So we need to get a modular platform, blade, screw, and augmentation. The anatomy of the bone and the nail needs to match. So we need a better nail in shape to avoid perforation and to avoid tie pain. Lateral or medial migration, cut through or going lateral, is a huge problem. This is a huge problem. This is painful. So we need options to lock the head element, and we need to protect this part to be a painful problem for the patient on the post-op. We need to avoid or decrease the implant failure. We need a better nail. The head element position, we need in a good position. So in order to put the screw in a good position, we need to see. So we need guide wire placement in a better view. We need friendly instruments that allows us to put the screw where it must be. We need better instruments to remove the implant, and we need additional options for locking and distal locking screw. So for this one, since we know the clinical problems, now we can design something based on the problems and based what the surgeon told us we need. And the first thing to do was give the population a better head element. So now with the TFN, we can offer for the surgeons a screw if they want to use the screw. We can offer the blade if they want to use the blade if it's a really bad bone, and both the screw and blade ready for the augmentation if the surgeon wants to. But he doesn't need another implant. Everything is ready or not for the augmentation. The lateral tie pain is a very, very frequent problem that the patient complained on the post-op. So what was done? We cut the distal part of the blade and the screw, and we offered the surgeons the possibility to static or dynamic locking this both blade and screw. So this is the short video to show the proximal locking. If you want to be a dynamic, you just go with the regular screw, the flexible one, all the way down and come back a quarter of turn. So it goes up and down and can compress the fracture. Do not rotate. But if you don't want even the collapse, you can go with a different instrument, go all the way down with a torque limit T-handle, and then we don't have the collapse or the dynamic movement of this screw. So this is in the same instrument, it's just up for the surgeon. The lateral protrusion, just cut as the bone ends. So this is the ideal end of your fixation, even with the blade or the screw, to avoid time pain. The second major problem was we need the anatomy of the nail and the femur to match. And here in Brazil, probably in India, this is a huge problem. The nail touches the anterior cortex and gives the patient tie pain 2 years after the fracture fixation. Or if it's a long nail, you can have a perforation of the anterior femoral cortex. So this was the first time an anatomic study was done, and instead of this one, they have, instead of 1.5 or 2 millimeter roll, they came with the 1 millimeter roll that is much better than the other one, and they can fix even the elderly osteoporotic bone. So now we have the 2 short nail, straight ones, but the 235 is already left and right to avoid touching the anterior cortex, and the long ones left and right based on the anatomy. So it's an anatomic nail for the surgeons to use on which size he decides to use. Based on the same MRI study, they were able to remove 0.5 millimeters and remove the lateral part of the nail to avoid lateral impingement and to remove less bone. This one was the bump created to improve the resistance of the cut to avoid premature failure of the nail. And this was a very nice design from the engineers. To make the surgeon's life easier, reduce the procedure complexity based on the surgeon's needs. Surgeons complained to us what was the problem during the OR, and we tried to improve the efficiency and give them better instrument. And this was the major complaint. I can't see the head. I can't see where the guide wire is. So we cut the aiming device to give you as soon as possible the position of the guide wire, and we can see that it's right on the correct place. And also we add something extramedullary. So this guide wire goes off the bone, and you can tell before we start to make holes into the bone where your definitive guide wire will be. So here, even outside, we know it's in the wrong position, but using the reference that is at the aiming device, inside the aiming device, you know in advance where your guide wire will be. So it saves time, saves X-ray, and saves holes into the bone. We know it's in correct position because even without the guide wire, because the chew marks are offside. So I just put it down, and now I know my guide wire will be here because the chew marks are guiding me. So it's saving and protecting the bone. So this is the correct position. This guide wire is outside the bone, and this one is inside the femoral head. So the reference matches the real one inside the bone. And this is the video that we used to show that we need to look for the true lateral in order to get the correct position of your guide wire. We have references to be used on the AP without putting any guide wires. So now I know my guide wire is right in the center of the femoral head without making any hole. And I just saw he's talking about femoral neck fractures that we need to hold to avoid rotation. We can do the same thing with our aiming device. And I know this second wire won't collide with the femoral head element guide wire. So we can hold the reduction and put the guide wire without any problem. It makes the life of the scrub nurse easy because everything is click on. So we just need one person to adapt every single instrument and assembly the nail and the aiming device. So this is make our surgery faster and more efficient because just one person can do everything. For the surgeons, we have different insertion guides. If this is your preference, okay. If this is your preference, okay. So it's friendly for the surgeon. No matter if the patient is a thin one or a fat one, we can have at the set all sources of instruments for the surgeons. And options. So I already told about the size of the nails from 170 to the 235, that's the short nail. This is right and left with several angles, depends on the patient angle. We can have static and dynamic locking. And for the distal locking, we have 3 screws, but in different planes. So it's a multi-planar configuration to improve the fixation on a weak bone, on a distal metaphyseal area. So now we can have a better grip and a better fixation even in osteoporotic bone. And if everything goes wrong, we knew 3% of cutout, we can't do anything with metal. So we need to improve the fixation of the metal to the bone, and the augmentation is the option that we have today to improve the fixation and try to eliminate this 3% of cutout. Like this patient with severe osteoporotic, we fix the fracture and we use this augmentation to get a better fixation. So this is the post-op. And another patient with 91-year-old, almost no bone, that is the fracture. And we fix and we use the augmentation, and he is the patient 4 weeks post-op, maintaining the reduction and walking prem-free. This is 12 weeks of consolidation. And last, the instruments for the surgeon. This was a must-have, is the hollow reamer to not open the fracture, but instead of putting the fragments apart, and not creating the path for the nail. With the hollow reamer, we actually create a hole to get the nail and not displacing the fracture. And if it's a long nail that we're using, we have the protection tube to avoid lateral damage every time the reamer goes inside the joint. So we use the plastic tube, and when we ream the center of the canal and not the lateral axis. So this is a very nice instrument for the surgeon to avoid displacement of the nail, because we have an eccentric reaming and we remove too much bone and lose the right fixation. So after we opening with the large ream, we insert the long guide wire, and over the long guide wire, we can use the protection tube to avoid the lateral damage, because the guide wire always goes lateral. And this is what the video is showing, that we put the protection tube here and we avoid the reamer to cut the lateral part of the bone, as you can see here on the video. So the indications for the new TFNA system are troch and subtroch fractures, the combination of troch and shaft fractures, some of non-unions and corrective osteotomies, but it's not indicated for femoral shaft and neck fractures, and not for shaft simple, because we have better instrument that removes less bone. So that's what we have today as an option for the surgeons. And I think that is what the best we could give the surgeons today is developed by clinical needs from the patient, from the fracture, from the surgeons, and from the instruments point of view. And they are based on the problems we had on the previous system, on the experience of several surgeons around the world giving their opinion, and they give you a global platform to treat almost all fractures at the hip region. Thank you very much for your attention, and I hope I could explain to you that it's not just a new nail, it's an improvement from previous system that we had in the market on the last few years. Thank you very much.
Thank you, Paulo. It has been one of the best lectures we have heard. So one of the issue in TFN that we are also facing is in the compression that we achieve at the end of the surgery. Like see, like all our surgeons are well versed with PFNA, and then they love to see the collapse of that fragment, and then the screw coming together, so that we know that we have collapsed 5 millimeter at the end of the surgery. But when we are doing with TFN with an external device, we are not able to get that often. So what is the reason for that?
You're talking about with the blade?
Yeah, collapse at the end of the surgery.
Screw.
Yeah.
But with both system, blade and screw?
Not both systems. It is a TFNA we are speaking. I'm asking.
Yeah, but the TFNA, we can use the screw or the blade.
Blade. I am asking.
Okay. What I use to tell people about my view of the compression is that it's not necessary. Just put the patient to walk on the next day, and it will collapse very, very nicely. But if you try to compensate your bed reduction with this compression, it won't work. And if you compress too much, you're going to have a lot of nail outside the bone, and it's going to be very, very painful on the post-op. So today, to be honest, I'm trying to compress as much as I can, sometimes with the clamp, sometimes with the bone hook or a forceps, and I just compress a little bit and leave the patient to walk on the next day.
So it has been a good walkthrough about the evolution that we have seen about the way it has been designed, and then now what are all the problems that we have been facing in trochanters that we have been trying to sort out with this implant. It's a good way of evolution, and then I think it's a good method of fixation. As we also use TFN nowadays, but compared to PFN and TFN, we do probably, if we use hundreds of PFNs, probably we are using only 10 of TFNs. So
it was more difficult for people from PFNA to move to the TFNA than the people from TFN to move from the TFNA. Because the PFNA, the blade rotates.
Yeah.
Just the tip. On the TFNA, the whole system rotates. And it's kind of a difference. Didi, I would love to tell you just something that is really important when you use the TFNA. Once you put the guide wire, usually the aiming device goes posterior. It drops down.
Yes.
And if you remember the slides of the bump, if you go with the reamer, the lateral reamer for the blade, we just ream the lateral one.
Lateral cortex, yeah.
Don't go very hard. As soon as you cut the cortex, rotate backwards, rotate counterclockwise to get into the nail, not rotating to cut the bone. The flutes of the reamer can engage that bump and can damage the nail.
Okay.
So they are working on a new implant, but if you go reverse, you protect your nail because usually the aiming device goes posterior. So that's something we learn doing the exercise and see, look, it's cutting the nail. So this is one tip we learned from the exercises.
Yeah.
So can we take some questions?
Yes.
So
Just-
for comparing PFN with one screw versus two screw, which is better?
Today, for the biomechanical studies and from the experience using the TFN for 15 years now, I'm go for one single element, and I use the blade in 90% of my cases, and I use a screw on 10%, usually young patients. I'm not using two elements since 15 years ago.
Then one more question from the same surgeon, Neeraj Singh. For a simple intertrochanteric fracture, whether a DHS is good or a PFN is good?
That's a nice question, and goes from the literature. For single A1 fractures, DHS can be a very good option if the lateral wall is okay, if it's not a very thin lateral wall, as well as the blade, as well as the nail. Because of the problems of the lateral wall today, in my practice, I'm not saying I'm right, I'm using the IM nail for all fractures, just to have one implant and decrease more momentarily. And the results are not different.
So what is your opinion, DD sir?
No, like in our scenario, cost also matters, because in a stable fracture situation, DHS works definitely well. So I think DHS is still a good option in a stable fracture. So I think because the cost variation is sometimes works in our country. So when you want to take that into account, DHS still a good implant for a stable fracture.
But Didi, when we look for the literature, and then CW and JK, they publish in stable single trochanteric 34% of intra-op lateral wall fracture. So now instead of a single, you have a very unstable fracture. And they use the lateral wall, the lateral plate. So that's why I use the blade, because I'm already working on the complication.
Yeah, see, like we also have published a paper where our DHS that we have used, we also have 20% lateral wall fracture intraoperatively. But what we have also found is that when we use DHS, if the lateral wall thickness is less than 25 millimeters, we found that it is the rate of failure is higher. That's why it is not a good option. So when we choose a DHS, we have to also look at all the other parameters. So if it is a right indication, yes. Whereas some of the fractures that are broken wide laterally, and then when the lateral wall is thin, then you would put a DHS, it is going to break. So that is what our inference was. So if the lateral wall is good, more than 25 millimeter, still a DHS is a very good option.
So it means that
next question is
we need to know, we need to be sure that it is a single fracture. It's not a potential unstable fracture.
Correct, correct. Yeah.
the next question is from Dr. Neeraj Jain from Janshi. What are the indication for short PFN and what is the indication for long PFN and why?
Based on the biomechanically and in our experience, I use the short nail for all single fracture, for unstable all 31, A1 and A2s. And for subtroch and the A3 fractures, we use the long nail. And also, I use the long nail if the patient has a total knee replacement. If the patient has a single fracture and a total knee replacement, I go for the long nail, and very, very long nail, to avoid that interference between the nail and the prosthesis.
Why you have to have a short and a longer version? Why don't we have an entire thing as a longer version only in all fractures?
That's a good question. There was some paper showing it's more time. It increased the operation time, increased the radiation time. And when you compare the fracture on the tip of the short one and the distal one, they're all the same. But it's much more difficult to treat the long ones than the short ones. That's why we use the short ones and not all long ones.
Because Paulo, one of the paper by Jeff Anglin, I think in Cochrane Review, if you see, he has said that the shorter nail has got a more peri-implant fractures. So that's why don't you have only a longer version?
Because we're going to move the problem from the shaft to the distal. Yesterday, I just operated one. I did it 15 years ago, was a long one, and now I had to fix the distal supracondylar fracture.
No, but you said you can have a pretty long, like you can go up to the almost like a subchondral bone.
That's what I'm doing now. But again, we had a better nail. We had a nail that is not violating the anterior cortex, the short ones. It's anatomical. So we moved more for a total knee type of nail rather than a straight nail bagging to break the bone. So I think it's going to decrease.
Okay, if Zakaria is ready, we can move on to his topic.
Thank you, Paulo. It was a very good presentation for us. It is all the evolution itself was such a good presentation to know. Lot of eye-opening statements that you made, and then especially the way the nail design was made, it is interesting for us. So we'll move on to the next topic. Zakaria, yes.
Yes, sir. Audible and clear. Sir, is an audible, sir?
Yes.
Sir, sorry, sorry. I am extremely sorry for the problem. Yes, sir. Proceed, sir. Unmute problem.
No, sir.
No, sir.
I'm audible, sir.
You have to mute Ramesh's laptop.
Sir,
Okay. Sir.
done, sir?
Yes, go ahead.
Yeah, sir. So, sorry for the interruption, sir. So today I'll be talking about an interesting topic, that is nailing tips and tricks in unstable trochanteric fractures.
In your left side corner, there is an arrow. You have to click that for slide advancement. Yes.
Yes, sir. So, trochanteric fractures are bread and butter to the trauma surgeon. They are present to us with a wide range of different difficult fracture patterns. And these fracture patterns ranges from undisplaced simple trochanters to fragility fractures in elders and severely displaced multifragment fractures seen in young adults, which are usually associated with RTA. So Evans in 1949 has classified the trochanteric fractures into stable and unstable fracture fragments based on the medial wall continuity. Medial wall continuity. So ever since the Evans classification, there are many other classifications which has come up, and all this classification has its own advantages and disadvantages. So all these fracture classifications helps us in better understanding towards the fracture pattern, so that we can provide a good fixation. AO has come out with a comprehensive classification which differentiates between stable and unstable. The A1 to A2 pattern of go through are the considered as the stable, and A2 to A3 are the unstable. So the unstable fracture patterns are the lateral wall fractures, last posteromedial fragment, fractures with subtrochanteric extension, transtrochanteric fractures, and the reverse oblique fractures. And for all these unstable fracture patterns, the choice of implant is an intramedullary implant in form of a nail. Successful fracture fixation starts from the patient positioning. Although all these fractures can be treated in a supine position on the lateral supine position or in a lateral position, in our institution we generally operate on a supine position with the fracture table with the boot traction. The main advantage of the fracture table is indirectly reduces the fracture and maintains the fracture throughout the procedures. So an IT fracture is usually typically reduced by traction, adduction, and internal rotation. So many of the stable fractures are reduced by these three maneuvers. So this is an X-ray within a simple IT fracture. So you can see the CM picture. This fracture is reduced only by traction, adduction, and internal rotation. But many times it doesn't occur. For a successful nailing, entry point is very important. The ideal entry point is from the tip of the middle to the tip of the trochanter. Whenever a patient is positioned in a fracture table, due to the traction, the pelvis is tilted externally and the proximal fragment is rotated externally. Unless and until this external rotation is corrected, entry will become difficult. So hence is a simple maneuver with a Steinman pin along the shaft and the cortex into the neck. Once it's internally rotated, the external rotation is corrected. Hence, it helps us to gain the entry. So here are the few examples. The case one is a 56-year-old female patient. It's a simple IT fracture. Once the patient is in the fracture table, AP view looks in the AP view, the fracture is reduced. In the lateral view, there is inflection of the proximal fragment. So how to reduce this deformity? This deformity can be reduced with a percutaneous technique. Through a stab incision in the anterolateral aspect of the thigh, with the CM guidance, a Homan's retractor is introduced. First, the Homan's retractor is introduced. The Homan's is passed along the anterior part of the trochanter and the shaft. Okay, with the CM guidance, you will be able to reduce it. Once you reach the fracture site, you have to rotate it anteriorly so that the fracture is reduced. So once the fracture is reduced, then entry is taken and routine nailing is done. But one thing has to be done is the fracture has to be held in a reduced position with help of your assistant. So once the cephalic screw is in, the retractor can be off. So if you see in the post-op X-ray, in both in AP and lateral view, it is anatomically reduced. This is another example of a 70-year-old male. This patient has a high subtrochanteric fracture with comminution. This AP view is in the CM traction and the lateral view. In the AP view, you can see there is the proximal fragment is adducted, the shaft is lateralized. In the lateral view, you see the distal fragment, there is a sag over there.
So how to correct this deformity? This also can be corrected with the percutaneous technique. With a stab incision, the posterior part of the shaft is accessed. Once the posterior part is accessed, you have to gently elevate it so that the posterior sag is corrected. Even the posterior sag is corrected also. You can see the proximal fragment is still flexed. So for this, you have to put a stab incision anteriorly. You can go and access the fracture site anteriorly. You can just retract it so that the anterior flexed fragment is reduced. So once the fracture is reduced, an anterior Steinman pin is inserted so that the fracture is held in the same position. And with this Steinman pin also, it is internally rotated so that the fracture is reduced, held, and internally rotated. All the three parameters for a successful nailing is achieved. So once the fracture is reduced, then entry is taken from the tip of the trochanter, and the regular nailing is done. The proximal cephalic screw is inserted. So once the proximal cephalic screw is inserted, the Steinman pin is removed. You can see the fracture is anatomically reduced. The third case is a 70-year-old female. It is an A33 type of AO classification. There is a trochanteric fracture with the lateral wall comminution. So all these fractures, all these lateral wall fractures has to be buttressed first before nailing. So all these fractures requires open reduction. In lateral incision, the fracture site is exposed. The fracture is reduced, held with Steinman pin. So once the fracture is reduced and wiring is done along the once this fracture is reduced and wiring is done along with the abductor and is held to the shaft in the figure of 8 fashion, and it is tightened. Once the lateral wall is buttressed, the nailing has to be carried on. So this technique is called as buttress first and nailing. So this is a 32-year-old male patient. This fracture has a trochanteric fracture with the ipsilateral shaft of femur fracture. So once the patient is positioned in the fracture table, these are the CM images. The right side image, the proximal fragment is externally rotated. The shaft is externally rotated. In the lateral view, if you see that the proximal fragment is flexed and the distal fragment is externally rotated. This rotation, this one has to be corrected with the wire in the shaft. You have to internally rotate the shaft. Once the shaft is internally rotated through a stab incision in the anterior aspect, the Steinman pin is inserted into the fracture site and it is manipulated. So once it's reduced, it's held with a wire. So if you see that in the AP and lateral view, the fracture is reduced, but in the AP view, there is an varus of the proximal fragment. This can be corrected with the help of an hook reduction clamp. Once you apply the hook reduction clamp, the fracture is reduced. So once the fracture is reduced, it can be held with 1 or 2 Steinman pins to hold on to the reduction. Then a routine nailing can be done. So these are the sequential images of the nailing which has been done. So once the after the cephalic screw fixation also, the fracture, we didn't get an adequate compression at the fracture site, but there is no much of valgus or valgus, and this patient went on to heal. So this technique we call is an intrafocal pin and hook reduction clamp technique. These are the reverse oblique fractures in a 60-year-old male patient. So once the patient is positioned in the fracture table, the proximal fragment is lifted off due to the abductor pulls. In the lateral view, the fracture is in a good alignment. So this flexion of the proximal fragment has been reduced with the help of a ball spike. This looks a reduced fragment. Then it has been held with a Steinman pin. So once this fracture is reduced, routine nailing is done. Whenever the nail is passed, we can see that the splaying of the proximal fragment. When the nail is introduced, there is splaying of the proximal segment. Hence, the nail was removed and open reduction was done. The fracture was reduced and the circulage wiring was done. Then the nailing was completed. So in these reverse oblique fractures, it is always to do open reduction, circlage wiring, then nailing. This is a 37-year-old male patient. He has a proximal reverse oblique fracture, the extension into the shaft. So once you position the patient in the fracture table, the fracture looks aligned. But in the lateral view also, the fracture, there's no varus or valgus of the distal fragment. But in the AP view, there is flaying of the lateral one. So this flaying of the lateral was reduced and then held with an Steinman pin, and routine nailing was done. Even during the rimming also, the proximal fragment was lifted off. We thought that once the nail is done and the proximal cephalic screw is inserted, it's going to compress the fragment. So we went on and go ahead with the nailing. But after nailing also, we found that the proximal fragment which is played, it didn't get compressed. So the nail was removed, circlage wiring was done, and the cephalic screw was fixed. Even though there is no much, of adequate compression at the fracture site, but the fracture is no varus or valgus, and fracture looks okay. So this is the immediate post-op X-ray, and this is 6 months post-op X-ray, and this fracture went on to heal well. The take-home message is, in all unstable fractures, nail is the choice of implant. Fracture involving the lateral wall buttressing first, then nailing. Once the anatomical reduction is a prerequisite before nailing. Never compromise the fracture reduction. It is always better to do an open reduction. Thorough knowledge of the vascular anatomy of the fracture is mandatory. Thank you.
Thank you, Zakaria. You have given all the points for reduction tips and reduction techniques in trochanter fractures. So is any questions we can take, and Paulo, any suggestions, any other techniques that you want to tell us?
That's fascinating, because you need to know all sources of reduction tools and techniques, because you never know which one we're going to use. What I like on the presentation is the step by step. You see the problem and you solve the problem, and you see the problem, you solve the problem. That's the approach, the menu approach. I really like. I use all of them, and the concept that we need to reduce the fracture. Don't rely on the nail without reduction. It's going to fail.
Correct. So reduction is the key. So it is nail or plate. It is only the reduction that matters. So, any questions? Dhanshekar has come.
Yes, sir. There is a question from Yasri Salam Siddiq from Aligarh. How to prevent lateralization of the entry point during nailing?
How to prevent lateralization?
Yes.
Of course, number one, like if the position was right and your entry point is going to be perfect, because sometimes what happens is, if your position is not good, if the obese patient is there, always the soft tissue will push your entry point lateral. So you have to make sure that your incision is little higher, and then get an entry point correctly, and then make sure it is tip of the trochanter. Start your entry on the medial to the tip of the trochanter. You will stay medial to it, and then it will be on right position. Whereas if you start on the lateral aspect of the tip of the trochanter, many times you will see that as you ream it, you will also ream the lateral cortex. So you have to completely be in control of that. And then when you are using the sleeve, ask your assistant to always push it towards the medial side, so that it doesn't lateralize. It doesn't pull out on the lateral side. So these are the points. And also entry point is crucial. For that entry point to be crucial, your reduction must be perfect. Suppose if you have a reverse oblique, and if there is an abducted fragment and you gain your entry, then it is also going to be a problem. So because if it is abducted fragment, when you are putting your homens, or when you are starting all, you will end up on the lateral side. So you have to be careful. So make sure that your reduction is perfect, and then get your entry, and you will never lateralize it. Most important is positioning. If your entry point to be good, these are the two tips: positioning and the reduction. Paulo, anything to add? You can add. So
I really like it. I'm so happy you said the incision. People, they just don't think incision it's important. If you cut too close to the greater trochanter, you are in trouble. So incision far from the greater trochanter. And second is, even if your starting point is okay, direction is crucial. If you go too in direction of the medial aspect of the femur, and when you take the AP X-ray, you see a bended wire. This is not good. It's gonna drive your reamer lateral all the time. The guide wire must go smoothly inside the canal, and then the reamer will follow. And the third tip, if you have the system, you have the protection tube, and the protection tube will protect a little bit more the lateral wall.
Devendra, Arun Kamal, anything to add, you can add. So
I think all the points have been told, sir, already. All the points have been excellently covered by Jakaria.
So there is a question from Dr. S. Murthy, Chennai. How to stabilize lateral wall combination?
So,
Patients fracture with lateral wall combination. What is the?
So trochanteric fracture with lateral wall, whenever there is a single chunk of the lateral wall is there. So we have to include the abductors along with the lateral wall, which has to be held in along with the shaft. So whenever there is a comminuted fracture which is there, it can be augmented with the plate.
Okay. And any tips when you are operating an osteoporotic fracture?
with the lateral wall, you mean? With the lateral wall fracture?
Generally trochanteric fracture with severe osteoporosis. What are your tips or precautions you take?
See, like when it is an osteoporosis, severe osteoporosis, number one you must avoid is varus. You must make sure that there is no varus at all. Even if you can keep it in little valgus. Suppose if somebody who is using a DHS also, if you go on to use a 150-degree DHS, many times it will heal, whereas not in a varus, number one. Number two, it must be an adequately fixed one. So all the osteoporotic always choose a nail, not a plate. So it is always good to choose only the nail. And then if you can think of an augmentation like what Paulo has given, no, like where you can put in your chronos into the femoral head, it is always good. So you can think of an augmentation with cement. All these are point, but never ever put them in varus. Always put them in a correct neck shaft angle or little bit valgus. It is preferable to use that. So reduction is the key in these situations. So Paulo, you can add any points for osteoporosis.
Now that's what you said. But usually osteoporotic don't break, they don't fracture in many fragments. They smash the bone. So when you use the nail, and that's why Didi said use the nail instead of the plate, is that the nail, the good thing about the nail, it's already the lateral wall. So if you get the perfect alignment, the nail will hold the fragment as a lateral wall, completely different from the plate. And again, never allow varus. Varus is you're postponing the second operation.
Okay. Thank you, sir. Then can move on to the next lecture.
Yeah, okay.
That is subtroch.
So I request Arun Kamal to share the screen.
Good evening all. Am I audible, sir?
Yes.
Is my screen is visible?
Yes.
Yes, sir. My topic today is difficulties encountered in subtrochanteric fractures of the femur. Yeah. Now, what makes the subtrochanteric fractures difficult? So basically, you see that there is a very short proximal fragment, which is often flexed and externally rotated by the pull of the iliopsoas. There is a gluteal muscle, which is abducting the fragment. majority of the cases, you also find an intermediate fragment, which is either a butterfly fragment or a comminuted fragment, and also a distal fragment, which is large and displaced medially by the pull of the adductors. So basically, we are going to address these forces and nullify the deforming forces and achieve a stable reduction. However, in some of the cases, it can be even more challenging whenever we are dealing with an obese patient and also when they are dealing with a comminution. So meticulous preoperative planning is very important in these kind of fractures because you have to work out from the preoperative x-rays. You have to choose the correct implant. You have to choose the patient positioning, fracture reduction, and also you should keep ready additional instrumentations like plates, wires, and screws in your armamentarium. So here is a case example. It's a 34-year-old female. She had a slip and fall, and she's a very short stature, only 5 feet height. And look at the medullary collar. Medullary collar is just 8 millimeters in diameter. So here nailing option is extremely difficult because you may splinter the bone. So this case, we went ahead and did a reverse distal femur locking plate and also supplemented with bone grafting. And this fracture healed uneventfully. So that's why the preoperative planning is very crucial. And next important thing is the patient positioning. So in the supine position, which is it is ideal position, it is also the gold standard. But however, some disadvantages that in morbidly obese patients, you may be finding difficult to gain a correct entry point. And you have to make sure that whenever you are positioning the patient on a fracture table, the pelvis should not tilt on the affected side. If it tilts on the affected side, then your trajectory to pass the guide wire and insert the reamer is going to be difficult, and you may end up in a wrong entry point. So always you have to move the patient's trunk away from the patient's body so that the upper part of the body is staying away and you get a good opening out in the lateral, the pelvis. So this is very important when you start the entry point. And Ostrom et al. Has noted that varus malalignment of the proximal fragment occurred majority of the time because of the two lateral entry. So here we have to start an entry point slightly medial to the tip of the trochanter. So on the traction table, the fracture leg should be adducted 10 to 15 degrees to achieve the optimal entry point. Coming to the lateral decubitus position, it is also a very useful position, especially in obese individuals where the deforming forces are being nullified because of the gravity. And also it is easier to complete the nail, but only the disadvantage is that sometimes it is very difficult to see the lateral fluoroscopic images in this position. AP can be appreciated, but lateral fluoroscopic images can be technically difficult. So coming to the fracture characteristics, there are many other fracture characteristics which can create problems, especially the medial comminution, when you have a lateral wall break, when you have a burst subtrochanteric fractures, or when there is excessive femoral bowing. All this can cause problems when you are dealing with a fracture situation. So I'm going to just brush upon what are the reduction tips when you deal with these kind of subtrochanteric fractures. So one important tip is using of a percutaneous bone spike, so that helps in your fracture reduction. There are other reduction techniques like use of a polar screw to adjust the nail tract. Then you can use collinear clamps or a cerclage wire, especially for spiral fractures. Let us discuss one by one. So this is a second tip where you're using a derotation pin in the proximal fragment. So you try to derotate the proximal fragment, and then if you are satisfied with your position, you can do a close nailing. But here there is a combination. You can see there is a shaft subtrochanteric combination. So here we have decided to do an open reduction and did a cerclage wiring. So after reducing the medullary canal, we have completed the nailing with a conventional method. The next important technical tip which will be very useful is your polar screw technique. So here you can see that the yellow line which represents the guide wire. So as you pass the guide wire, if your medial wall is not intact, it can just slip away and go medially. So in this case, we have to use something like a block pin. So the red color ring which shows that a block pin like a Steinman pin was used, so that the guide wire and the reamer goes in the more lateral, and it goes parallel to the lateral wall of the trochanter. So this again, you can finish your reaming, and then at the end of your nail fixation, if a fracture is adequately stable, you can just remove the Steinman pin, or you can substitute with a polar screw. So in this case, it was relatively, the fracture was not that stable. So we supplemented with the polar screw. And this is the final image. We can see the very good lateral wall and the nail. There is no varus in the head. And we were able to achieve a very good reduction. The another important useful technical tip is that whenever dealing with an old fracture, so this case was a 50-year-old male who presented to us 2 months after the native treatment. So the fracture was very much difficult to reduce the fracture. It was not that mobile. So we had to do an open reduction. And here we have used a 4.5 DCP as a temporary reduction tool. So this helps to keep the fragments in alignment till you complete your reaming and complete your nail. And finally, after doing the locking, you can remove this plate. It's just a temporary reduction tool. This can be always be available in your theater because a very cheap implant. So you can keep this ready in your armamentarium. So now coming to some of the another case examples, this is a 43-year-old male with a medial comminution. So here you can see there is extensive comminution on the medial side. So I hope that most of the surgeons will prefer an open reduction in this case. So always in these kind of situations, never hesitate to open the fracture site, do an open reduction. You reconstruct the medullary canal, you correct the varus deformity of the neck, and then you start your entering point, and then you complete your nailing. So in this case, we have opened the fracture site, did a cerclage wiring, and completed the nailing with a static locking. And we were able to get a reasonably good alignment. And this is the follow-up at 4 months, and this is a follow-up at 1 year. So it has got, the fracture is healed uneventfully. The next thing is like whenever having a wedge comminution fracture, the lateral wedge. So this is a 47-year-old male. He had a fall from two-wheeler with a lateral comminution. So here again, the same technical tip I used. You have to use an open reduction because you have to reduce the fracture first. You have to secure the fracture with an encirclage wiring. Then you can correct the varus by using a derotation pin. Then you can start your entry point and complete the nailing. So when you follow these steps one by one, you will not end up in problems. Majority of the times you will get a reasonably good alignment and the fracture will heal. This fracture is united at the end of 1 year. Another case, a 64-year-old female with a slightly subtrochanteric fracture with a large lateral spike, and the shaft is displaced medially. So sometimes you may be successful in a close reduction when you're using like some Steinman pins or like a pusher rod we can use, but sometimes we may not be successful, that you have to use an open reduction and cerclage wiring. But always make sure that you reduce the fracture first before reaming. Otherwise, you may end up in a varus fixation. So this is the final image. The fracture is healed uneventfully. This is another example is a 56-year-old male with a segmental femur. So he had presented to us 6 months following a non-union. So here you can see that both it's a segmental fracture, so both proximally and distally the fracture is not healed. So what was decided was to do an open reduction, bone grafting, and augmentation plating. This is the second surgery, but ultimately after end of 2 or 3 months the implant broke. Then the implants were removed, and then the fresh nail was introduced. Then again bone grafted, augmentation plating was done, but ultimately even at the end of 3 or 4 months this also failed. So when you critically analyze this fracture, in the lateral view, you can see that entry point was very much posterior. So that is why the same entry point was used again and again. So biomechanically it was very unstable. The fracture failed. So now the same thing, it was revised. So we have corrected the varus deformity. So you can see that there was angulation between the proximal and the distal fragment. There was angulation of nearly 15 degrees. So this time we corrected the varus deformity, we removed the nail, and then we exchanged with a like slightly thinner diameter nail. And then we have used a sturdy implant. This is actually a reverse distal femur locking plate. It's a very sturdy implant. So we have corrected the biomechanics. So once we have corrected the biomechanics and then we have reduced the fracture well, it went on to heal. So here the important learning tip is that however good your fixation may be, but if you don't correct the biomechanics, you may fault, you may end up in failure. So these are some of the intraoperatively checklist that will be helpful for you. One is the varus malreduction. How do you prevent it? So avoid a lateral starting point. The reamer should always be parallel to the lateral cortex in the AP view and central in the lateral view. For rotational malreduction, how to avoid it? So you have to always, before reaming, achieve an anatomical reduction and avoid any cortical discrepancy. And next important fallacy is the leg length discrepancy, especially in the comminuted fracture. So always preoperatively measure the opposite femur length and be prepared with the nail size. So by following these simple tips, you can avoid some failures. This is my take-home message. So never start entry point before reducing the fracture and correcting the deformity. So if attempted closed reduction fails, never hesitate to do open reduction. For spiral fractures or split fractures, cerclage wiring should give us best results. For lateral wall break, plating alone or a combination of nail with plate is a good option. Thank you for your kind attention.
Thank you, Arun. So thank you. Again, you have given a lot of points for reduction techniques. So anything to be added by our colleagues? Paulo, you can tell any other points you want to add for reduction.
You have to unmute yourself.
Unmute.
Paulo, you have to unmute. Yeah.
Yep. That was a great presentation. And again, we need to know every single trick, tips, instruments to get a good reduction. What I like to use on substrokes is the joystick at the calcar. I think it gives me the true AP, and without the true AP, there is no chance to get a starting point. The entry point needs a true AP. And it gives me the true AP and gives me the reduction tool that usually is an extension and internal rotation of the proximal fragment. I feel it's very, very useful. The second tip I learned with the guys from Korea, CW, that is the long forceps to do internal rotation of the proximal fragment. It helps a lot, saves a lot of time, a lot of radiation, and it's a very good tool that is not expensive. Everybody has a long forceps. And
Dr. Paulo, I have a question.
Yep.
Yeah, whenever there is a medial comminution of the subtrochanteric region, which is extending up to the lesser trochanter, when we start, do you think we need to often open the fracture site and then do the nailing, or how to avoid the proximal fragment getting into abduction and the nail being escaped through the soft tissues onto the medial side? What are your tips for this?
You mean when we insert the guide wire?
Yeah, from guide wire onwards, from the and when we put the nail also.
If the joystick can't be used because of the comminution on that area, usually is a very short fragment, then I go with the joystick from the lateral side, as the guy from trochanteric presented. You put one anterior and one posterior, and you can manipulate the fragment. But as he said on the take-home message, do not hesitate to reduce the fracture. And reduce the fracture for me means avoid varus and flexion. If it's a comminution, I really don't care about the medial comminution because the nail can hold it. What the nail cannot hold is the fragment in varus, in flexion, without the medial support. If you use plate, then you need a good medial support. Otherwise, the plate is going to break. That's why for me, subtroch means plate, means nail.
So there's a question from Prasad Joshi. Is there a role for primary bone grafting in subtrochanteric fractures?
Paulo, you want to take it? So primary bone grafting in subtrochanteric fractures.
No, we don't use with the nail, and actually when you ring, you are bone grafting, but I don't open to put bone graft when I use nail.
No, like in the primary bone grafting scenario, maybe when you have struggled a bit in subtrochanteric fractures, you have opened it and then there was a struggle in getting your reduction. There is, as Devendra said, there is a medial comminution. So because of your open reduction, yes, sometimes you can add your bone grafts if you want to. If there is an allograft facility, it is simpler because you don't add any morbidity. So that is why you can think. But generally, if your dissection or anything has not violated a lot of soft tissues, nail will be good enough. So that is the only thing, because your bone graft will be required only in case you have violated a lot of soft tissues.
But do you struggle to get the medial fragment through here?
No.
Because, yeah.
But what Devendra was asking was, if I had understood properly, you said that because there is a comminution and your entry point, as it goes, lot of the times your guide wire will goes into the soft tissue on the medial side. So one of the technique that you can use is like there is a reduction sleeve. Suppose if you have a reduction sleeve, then always try to pass parallel to the lateral cortex, and then maneuver it to the medulla on the medial side, to the distal fragment. So it will avoid your penetration onto the medial side. So I think if you have any doubt on that side, you have to use a reduction sleeve. Through the reduction sleeve, get the guide wire and make sure that the reduction sleeve is parallel to the lateral cortex, and then use the pusher for the lateral fragment, and then get it into get the guide wire onto the medulla into the distal fragment. That is the best way to go ahead.
Yeah, many times when reduction may not be a problem, sir. Once we reduce, to maintain that reduction throughout the procedure of nailing till we complete the locking will be difficult. Any tricks on maintaining the reduction till the end of the procedure?
One of the trick you can also do is, anyway, for subtrochanter fractures, when you are doing a nailing, there is an incision that is going to come for your proximal screw. So same incision area, you can extend it a bit, and then just pass a plate proximally and distally, and then hold on with the clamp for the distal fragment, and that plate will buttress the proximal fragment and keep it in alignment. And then you can get the procedure done, and at the end of the procedure, you can remove that plate. That plate is used only as a reduction tool.
Yes, sir.
One thing that I really feel comfortable doing is the joystick, either with the long forceps or with the Chinese screw inside the canal. You can manipulate as a joystick. The really tough one is when the proximal fragment is really short. It's just a piece of trochanter, and the neck is nothing else. And then I think that to get a plate, a hook plate or whatever, to hold it temporarily, it's a great tool to reduce. And going back to your question that Didi make it clear for me, if your guide wire is going medial, one tip is just open the drill, just make a little bit 3.5 and bend the long guide wire. Make a very sharp turn at the tip of the guide wire, and then it goes and aim towards the lateral. And then when it hits the lateral distal fragment, then it slides down.
Okay.
Then, Shekhar, any other questions? Then we can move on to.
Yes, sir. We can move on to the next topic.
So because we are coming close to 2 hours, we'll finish it.
Yes.
Yeah. So
there are some questions about THR and trochanteric fracture, probably which we'll address in next webinars, I think.
Yeah. Yes, Devendra.
Yeah. Good evening to all of you. I wish you all a very happy Ganesh Chaturthi. I'm going to talk about how to salvage a failed trochanteric fracture. Unfortunately, it is a serious concern now in the current situation where the geriatric population is very high. The incidence of trochanteric fractures is on rise. In a year duration, if you see, the incidence of trochanteric fractures alone are about 370 cases in our institution. However, due to recent advances in the technology as well as availability of the newer design nails with very minimal failures, we could see only 6 patients had failures in 2019. Among them, 4 patients required revision fixation and 2 patients have undergone hip arthroplasty. Failed internal fixation of a hip fracture is always a problem. It results in severe marked pain and it results in disability, difficulty in walking. And the treatment also is very difficult. It is a challenge to any orthopedic surgeon. The important strongest predictors of failures are tip apex distance more than 25 millimeters, and positioning the helical blade or screw inside the lateral cortex of the greater trochanter, it can cause failures. These are the two important predictors of the failures. In a situation where we see extreme osteoporosis of the fracture and the non-union of a long duration and associated comorbidities with acetabular erosion, the total hip replacement is a better option than salvaging this kind of fractures and ending up in poor results again. Here is a 75-year-old gentleman who had a previous fracture some time ago and then sustained recent fracture on left side, which is a comminuted one, which is unstable fracture. And immediate post-operative X-ray shows good stabilization of the fracture with DHS. And however, the 6 weeks post-operative X-ray, we can see that there is a medialization of the shaft, which is happening. So when to suspect a failure by seeing the X-ray and by assessing the patient, when to suspect, how to diagnose whether this patient will end up in a failure or not. Important clinical symptom is the persistent pain on walking and non-physiological motion and associated with progressive deformity, and X-ray when there is no radiographic evidence of healing, and movement of implants when it is seen in the X-ray. We need to suspect the failure of the trochanteric fracture. And this patient at the end of 5 months shows there is even more medialization of the shaft compared to the trochanteric position. When the medialization is more than 1/3, it is considered as fixation failure, and it needs if we need to address the fracture and intervene at this stage when there is more than 1/3 of the medialization. And also the medialization not only happens in DHS implant, it can happen even with the intramedullary nail as well when in severe comminuted fractures. Here is a patient with a reverse oblique kind of fracture with extending into the subtrochanteric region and up to the trochanteric above the medial to the tip of the trochanter, which was stabilized with 2 screws intramedullary nail. In the immediate post-op X-ray itself, we can see that the shaft has been medialized, the lateral wall is not been reduced properly, and 2 screws have been used. There is a lot of debate whether to use 1 screw and 2 screws, and by now with the excellent lectures by Dr. Paulo and others, we know that single blade is better than the 2 screws because the lesser amount of reaming, lesser amount of bone is taken out to insert the helical blade, and more stability compared to 2 screws, which can result in failure. And this patient went on to have a loosening of the screws with failure and lateralization of medialization of the shaft. And this patient required revision procedure, and we need to correct the medialization by bringing the shaft and the lateral cortex of the trochanter in correct alignment. And for that, extramedullary plating fixation was done by using distal femoral locking plate, which is reversed and applied onto the lateral surface, and it went on to heal very well without any problems. And this fracture which we saw before is a 75-year-old gentleman where there is a medialization. This is X-ray at 10 months post-op, and now the question comes whether to intervene at this stage or whether to wait, whether the healing happens at this stage. And the answer is how long to wait. The answer is when there is a suspicion of failure, it is better to act as early as possible, and we can give a good quality of life and reduce the pain of the patient. And FDA guidelines shows if there is no healing progress for a period of 3 months continuously, we need to consider that it is a failure or a non-union, and then we need to intervene. And beyond 9 months, we generally consider all the fractures that it is a non-union, and better to intervene as early as possible. Having seen how to diagnose the failure and when to intervene and do revision procedures, what kind of procedures we need to do? Coming to this question, we need to understand why the fracture has failed and what is the problem that with which the fracture has failed. We need to assess the patient and the X-ray based on the following factors: stability, contact, deformity, biology, and the mode of failure by which the fracture has failed. And we need to consider the osteoporotic level also and the activities of daily living of the patient. Let us look at how the DHS fails. In a situation when you use DHS, the DHS can cut through superiorly by moving superiorly and then eroding the superior portion of the femoral head. However, in this situation, the inferior portion is still appears to be non-violated, and this can be used to secure future fixation. And what kind of technique to use? And in this X-ray, when we see the helical, the Richards screw is completely out of the femoral head. Appears to be the whole femoral head is not violated. Only the inferior and posterior portion is partially was held by this Richards screw. And in this situation, we can use the superior portion of the femoral head and then pass different implant, and then we can achieve complete union. Here is a elderly gentleman with the comminuted 4-part fractures, where greater trochanter, lesser trochanter, humeral head, and shaft are grossly comminuted, and there is a marked osteoporosis. DHS screw has been applied in the superior portion, and the inferior portion is still appears to be non-violated. Here the tip apex distance is more, and further it went on to have a medialization, and here the lateral pillar appears to be intact onto the lateral surface, where the greater trochanter is abutting the humeral head, and then there is a medial gap with medialization of the shaft. In this situation, it is better to intervene, having seen that it is going to further medialize and fail. And we used the DCS screw and corrected the varus. It was only remaining 5 degrees of varus at the end of the procedure. It went on to heal completely without any problems. So it is better to use the inferior portion of the femoral head, and have a good purchase with the dynamic condylar screw, which is and the plate which abuts the lateral cortex and prevents the medialization. Another mode of failure is the medialization of the shaft, where the shaft along with the barrel plate moves medially. Here is a gentleman, 53 years old gentleman, who had DHS fixation done with for an unstable fracture. There is a medial gap as well as medialization, and in this situation, it is tough to decide how to proceed further. If we look at carefully, the inferior portion still appears to be non-violated, and the fracture is in varus. The tip apex distance is more, and we need to correct the varus as well as we need to address the medial gap and prevent the medialization. Here we have valgusized the hip by using DHS implant, and then went on to heal completely. When we attempt second time to operate on any failed trochanteric fracture, we can be successful up to 82% and achieve good union with an average union time of 6 months time. This is another mode of failure where humeral head is intact and there is no loosening of the Richards screw. However, the barrel plate is getting pulled off from the lateral surface of the shaft, and sometimes we can see there is a breakage in the head neck junction of all the screws and result in failure. In this, we can see that the humeral head bone stock is good, and then the Richards screw is not loosened. In this situation, we can change the barrel plate alone and then correct the varus, and we can augment it with bone grafting as well. However, not all fractures, all failed trochanteric fractures, we can be successful. Sometimes we can see failures as well. We cannot escape the statistics. Each surgeon has got a failure rate, and here is a patient where initial failed fixation, which was again fixed with DHS, with using allograft as well to prevent varus collapse, and then fixed bone grafting was performed, iliac bone grafting. However, still it went on to fail with the superior migration and requiring total hip arthroplasty. In summary, the success depends on identification of the failure of the problem, and then appropriate management is required to correct the varus deformity, medial bone loss, and then lateral cortex needs to be buttressed. Then we'll achieve good results. Thank you.
Thank you, Devendra. So now we'll invite Paulo to give his comments on this, because you see, like, all the failures that you have been showing is on the DHS side, isn't it? A lot of failures are you have shown in the DHS. So in any of the trochanter, suppose if there is a nail and that has failed, so what would be the mechanism by which it fails?
Usually a reverse G effect can happen if we have used 2 screws in the femoral head. And if the helical blade has been used, either it can migrate inside, it can cut through, or cut out can happen, or sometimes the screw can back out if there is no good purchase in the lateral wall as well.
Paulo, any comments on?
No, there was an excellent presentation and put everything on the right place.
Thank you.
I really think that as a trauma and recon surgeon, there is a place for reconstruction, and you gave the right indications what to look if it's okay or not to go for a reconstruction or arthroplastic. And there was a lot of good tips and tricks. For the nail, I think we can go either cut out, cut through. Those two are the most common. And what he said is the key. You can wait, but don't wait too much. If the patient is not doing okay, the symptoms he described, get the X-ray. Don't wait for today's X-ray. Look for the last week, the last month X-ray. They tell you if it's going okay or not, and don't wait too much. Otherwise, there's no head for fixation. And the third thing I would like to talk about is today, we have the augmentation. So we have the augmentation for the DHHS, we have the augmentation for the TFNA, and there is another good thing that we can use for recon on those fractures if the head is okay, if the acetabulum is okay.
Yeah. So any questions, Dhanshekar, waiting?
Yes, sir. There are a lot of questions on other topics as well. One is, what is the role of hemiarthroplasty in comminuted trochanteric fracture?
So,
in comminuted trochanteric fractures, if the bone is, if the osteoporosis is too severe, even sometimes when we use the PFNA2 or TFNA with where the perforations are there, to augment it with cement, still the possibilities of failure are there. In those situations, we can secure both greater trochanter and lesser trochanter by using circlage wires, and then do hemiarthroplasty with cementing. Cementing is very important in those situations. We also have used in those situations hemiarthroplasty, and it gives a good result. The only indication is too severe osteoporosis.
So even hemiarthroplasty also is a good option if there is a very, like, elderly, say beyond 85 years, or somebody who has come with trochanter and comminuted. Definitely they are going to be severely osteoporotic. But they all see, like, if there is a very good article which says that lot of unstable fractures happen in a patient who are highly comorbid. See, like, because those who are having lot of comorbidities, and their daily activities are going to be less, and then they are definitely will be osteoporotic, and even a fall will result in an unstable fracture. So they have correlated very well to say that comorbidities are more with unstable fractures. So in those scenarios, if they are having very elderly, I think bipolar is a good option.
I think if there is a lesser trochanter combination, we use a long stem and use a bipolar, which is a fast procedure and it allows immediate post-op ambulation.
Yeah.
Next question is, what is the incidence of heterotopic ossification after femoral head fractures? Do you do any prophylaxis, Ramesh?
Yes, sir. If the incidence of heterotopic ossification is seen up to 25% of the patients in femoral head fractures, but it is more common in people who have had acetabular rim injuries, where there is an increased incidence of the gluteus maximus contusion. It's high, and also in cochlear lamella trochanteric flip osteotomy, the incidence is more. Our incidence is up to 12%, but it has been reviewed up to 25% of the cases. In my series, when the acetabulum fracture, my series is increased in patient who underwent a posterior approach with the trochanteric flip osteotomy. So when there is I do a trochanteric flip osteotomy, I start them on indomethacin at least for 6 weeks time. Otherwise, only a Gaunt's procedure, I don't, without preserving the short external, I don't put them on indomethacin. That is the protocol I follow.
So for a posterior wall fracture or posterior avulsion, you treat them like a acetabular fracture. You put them on
a transverse posterior wall or a posterior column with the femoral head fractures. So when you do a posterior approach for fixing the column and doing a trochanteric flip, I add them indomethacin.
Okay, next question is on fracture neck of femur. There are 3 questions. What is the best reduction method for fracture neck of femur? Either flexion technique or extension technique, either open or closed?
Who spoke? Well, Murugesan can come in. Well, Murugesan, you can answer. But however, see, like, as far as our reduction technique is, we always do it in extension method. And also, like, we have nearly, like, I don't remember any, last year and all, I don't remember anybody we have opened for a open reduction. I have majority, we always do by closed methods of reduction. So, and we are successful in reducing it nicely in both AP and lateral view. We have never found a problem in closed reduction. So I think if somebody has got a doubt, I think they have to come and visit us. So I think that will definitely help them out. So Paulo, what is your opinion on this question?
I agree with you. I go for close reduction, careful, systematic X-ray at the OR. Use the image. I play around with the image, not just AP and lateral. Go oblique and see. And usually you can reduce much more than you think. In young patient with a lot of comminution posterior, then these ones probably I will need an open reduction. But as you said, it's exception. It's not protocol is not mandatory to open all of them. No, I don't. I start with closed reduction.
Most of the time we try to achieve good reduction, good anatomical reduction. Sometimes we do accept a reduction in slight valgus. Yes, and most important thing to avoid is varus and retroversion. And so sometimes when we don't get reduction with closed maneuvers, we can also use percutaneous pins into the lateral aspect of femoral head, especially to correct the varus and give a lateral pressure on the trochanter to get the compression and pass the pin in across the fracture site to secure it in good reduction.
Can I add something? It's very common here in Brazil for people to do femoral neck in a conventional radiolucent table. And they reduce and they fix with some wires, and then they move the leg to get the lateral view. In my opinion, this is the best thing you can do to lose your reduction. So I reduce it, I keep it on a regular table, on a fracture table, and I move the image. So I think with this one, we improve the quality of our reduction, the perception, and that's why probably we don't open as much as the other guys.
No, all our fractures are done in traction table. None of them are on translucent table. All of them are on traction table.
Again, well, Murugesan, is there any, is valgus reduction is better than anatomical reduction in case of comminuted fractures, neck fractures?
Yeah, In comminuted fracture, it's very difficult to get anatomical reduction because it usually the comminution is in the inferior aspect and it is very difficult to match the calcar. So if that it is better to have a slight valgus reduction and in these fractures as than getting a non-anatomical reduction or trying to do an open reduction.
So is there any role for muscle pedicle graft in fresh fracture neck of femurs?
There are articles which have been reported that in the presence of significant posterior comminution, an augmentation must be done. There are various forms of augmentation such as muscle pedicle graft or free fibula has been reported in literature. Muscle pedicle graft can also be done. But we follow in our institution, whenever there is significant gap, we do an impaction bone grafting, which fills the void and also extends the fracture union before failure occurs.
No, we haven't done any muscle pedicle graft. Our experience is zero, so it is difficult to comment on muscle pedicle grafts. Follow you? Anybody in Brazil is using a muscle pedicle graft?
They use it when I was a resident because the microvascular surgery was microsurgery was everything. But since then, I never saw, and I never had experience, and we don't do it. It might be okay for complications on young patients, but not for fresh acute fractures. We don't use it.
Just want to add, sir, the muscle pedicle graft, maybe 15 years ago, it was quite famous, and very few surgeons know how to do it, and then technical expertise also required is too high. But in the last 15 years, due to advances in the total hip arthroplasty, if you have a failed neck of femur fracture, primarily we don't use muscle pedicle graft, and if you have a failed neck, total hip arthroplasty nowadays gives a very good result with the longevity of the hip more than 25 years. And there is no reason we have to go for such a extensive surgery which requires vascular expertise, and the failure chances are also high.
Okay. So if the Powell's angle is 90 degrees, how do we manage that?
The more vertical fracture line, we have to try to convert it more horizontal. It is what we try to do is we try to get it near 30 degrees. But more we try to correct will cause more lengthening also. So it is ideal to not to correct more than 50 degrees. So we do a valgus osteotomy, make the fracture more horizontal so that there's compressive force across the fracture site and it helps in healing.
So how much valgus maximum will do? Because if it fails and patient comes for subsequent total hip replacement, it's going to be difficult for the revision surgery. So is there any limit you stop with the valgusation or you go with the fracture pattern?
Too much of valgusation will also result in knee problems. So it is better not to.
Dhanshekar, it is always preferable to stay within 30 degrees of correction of this valgus, because what happens is even then also it should be like an osteotomy that is done, like you should not carry on to the almost to the opposite cortex and get the entire 30 degrees done. What is when generally done is halfway through you can close and immediately you can open it halfway through. When you do that, the shift that happens won't be too great and your replacement will not be an issue. So it is well described by G.S. Kulkarni. He always keeps telling about it. So you have to go halfway through with an osteotomy and then correct half. Suppose if you have to correct 30 degrees, there must be a 15 degree of close, and then on the inner side there must be a 15 degree of opening. So that means it will be easier for you to get it corrected that way. So
there is one interesting clinical scenario. Say a patient within 40 to 50 years of age presenting with fractured neck of femur after 10 days. What is the ideal mode of treatment?
In a young patient, we try to salvage the hip joint and we try to fix the
No, you said 10 days, no?
10 days old, yes.
Yeah, 10 days is still, you have to treat it like a fresh fracture only.
Okay.
So,
Is there any difference in approach in children when it comes to proximal femur fractures?
like depends on what the question is about. Is it like a neck fracture or is it like some sort of subtrochanteric fracture that he's meaning? See, like suppose if you have a subtrochanter fracture where you have to nail it, probably a lateral entry, more lateral entry is preferable because they know that if you are more going to be medial, there can be an avascular necrosis. So those issues might come in. So they know that there is also nails which are made like a lateral entry nails are there. So those types you can use. Adolescent nails that you can choose. Whereas if it is like a femoral neck fracture in a kid, you know that you can violate the physis and go and have a good fixation because you need to have a stability. You must not stop before the physis. If there is instability, again, you are adding to the problem. They can come for another surgery. So you have to go through the physis and have a best purchase. Stability is the most important thing. So
Again,
follow anything to add, please keep adding.
No, for neck fractures in kids, that's what you said. It's surgery. We need to fix it. We have better implants now. We can use the locket plates. If it's too young, I preserve the physis. It's close to the end of the growth, like 15, 16 years old. I prefer more fixation rather than the biology of the growth plate. And the problem is the AVN. The higher it is, the AVN, it's a high risk for kids.
Any comments on medial anti-glide plate?
For femoral neck fractures?
I don't know what he means. He's just asked a question.
He's talking about the buttress plate, which we already spoke.
Okay.
I think that is what we were discussing. I think probably is meaning that medial plates that are being used for a femoral neck fixation. But we already spoke about it, saying that it is like, yes, you can do it, but however, there is a lot of opening reduction and all those things that happen, and revisions when it happens, it's going to be an issue. So I think I have never done a fixation like that, so I have no experience to tell about it. Paulo can tell more about that fixation.
I really, in my mind, I may be dumb or whatever, but if you see all the X-ray he showed, all the CT, it's a posterior displacement. In order to buttress, you need to put this plate posterior. If you put it inferior, these screws are the ones responsible to hold the fracture. And we know it's not going to work. So in my opinion, it's good for the X-ray. It's a lot of dissection, but does nothing for the fracture. It's my opinion, and I've seen a lot of complications, much more than the benefits.
Next question is
yeah. Sorry, sir. I have a question regarding the previous case. 52 years old gentleman with 10 days old neck of femur fracture. I'd like to ask DD sir whether impaction bone grafting is better to do in 10 days old fracture along with DHS fixation, or whether we can go ahead and do only cancellous screws fixations.
See, if the year is 52, suppose somebody comes with 52 years and asks you what is the best, actually all the controversy can come in, because even 52, if Dhanashekhar is given, he will say, I will go ahead and do a THR, because it is a fixation versus replacement question will come in this age group. Whereas if you ask, okay, 10 days old, if you are fixing it, okay, you have to do the best fixation that is possible in that area, because as Paulo said, up to 5 days, there is a good vascularity that is maintained. There is a study. So like that, if you look at it at 10 days, you can also go ahead, nicely fix it. And if you want to give them the best for that, even do impaction grafting. So it is the call that you have to take on that case by case. So you have to see that patient personality, comorbidities, what is there, and then you can add to that and decide what is it. But if you are deciding on fixation, yes, go ahead and do the best that is required. If you think this will require a bone grafting, you do that. If you think he needs a DHS with an allograft, you do that. Whatever is best in your mind, you have to do that.
Okay.
The next question is there a difference in entry point for TFNA?
TFN and then TFNA and the PFN, the entry point are all the same. Tip of the greater trochanter. With a good tip, if it's a subtroch, go a little bit more medial to avoid varus. Do not accept
Yep.
Go ahead.
How to use a cerclage wire safely?
You can, there's one very nice way to use it if you have the minimal invasive cerclage wire, but it's expensive and you need to buy it. Otherwise, it's to have all the hooks from the total hip system and the cerclage system, and do not devitalize, do not do stripping, and be careful on circumferential going to the bone. It's a safe procedure if you keep your hands and knife away.
Cerclage wiring, when you are doing, like as Paulo said, that minimal invasive wire passer is good, but you must be aware that there is a lot of complication that can also happen, especially you can injure the vessels. So we have also reported vascular injury after using these type of wire passers. And it has to be like you have to take it very close to the bone. We have to remain very, very close to the bone always. When you are passing it, make sure that you are touching the bone and going, and then you meddle it there, it's okay. But if you are going into the soft tissue, especially in the way one of the Zacharias presentation, you saw that cerclage wire is very close to the lesser trochanter. If you don't follow that, you will catch the circumflex vessels. You have to be careful. So we have reported a case of a profunda injury. We have reported a case of even a femoral artery injury. So you have to be careful. So I think it is not very easy to be, this instrument you have to be extremely careful. So you have to be careful.
Can cerclage wire slip into the fracture and cause non-union?
Now, once the cerclage wire function is, especially it is in the intraoperative, so I think many times it is helpful in the intraoperative phase. And then once all the nailing is over and the screw is in good position, the fragments doesn't change much. So it just remains there. You don't have to take it out. But a lot of people will say that some of them would have asked me, like, should it be removed? So there is no need to remove it, because at the time of wire passer, whatever damage you would have done is done. So I don't think it is going to change any further. So you just retain it so that it in a different planes, it will keep the fragments in a right position. But when it comes to a cerclage wiring near the lesser trochanter, if you see the diameter is more, and then distal to that, there is a diameter is less. So sometimes the cerclage wire might slip out. So if your screw is not holding the fragments, if the cerclage wire slips out, suppose if there is a change that happens later on, yes, it can lead on to a non-union. So
just want to add a few.
Yeah.
One more, this one, sir, regarding cerclage wires, we tend to do nailing with the adduction position of the limb. And once we reduce, either by closed method or open method, once we reduce the fracture, when we are passing the cerclage wire passer, all the including the synthesis instrument and the conventional one, like a half of the circle it is seen. When we pass, it is the curvature of the wire passer doesn't match the curvature of the femoral bone. So it tend to go more medially and then catch the soft tissues. So important trick is that we need to abduct the limb, and so that between the central post and then the femoral bone, the soft tissues should not get caught too tightly. If you abduct the limb, the tissues will become soft, lax, so that the movement will be more. When we tend to pass the wire passer, it can slip out of this. It won't catch the vessels. So that is one important trick. We need to abduct the limb when we are passing the circularized wire passer. And in the initial phases of your circularized wire application, it is always better to open it and then see by vision and then apply it. By closed method, sometimes because the wire passer, it goes and catches onto the other side, and exactly which is out of your vision. So you never know whether we are catching the vessel. Sometimes immediately we may escape by without any injury to the vessel. But if there is a small tear in the intimal region, it can form a pseudoaneurysm, and patient will come back after 6 months or 8 months time with the pseudoaneurysm thigh swelling. So that is also quite commonly we have seen in our institution. So it is important to be very, very careful while passing the circularized wires. Because the profunda femoris artery, that is deep femoral artery, is very close to the bone. That is the one which most of the times we tend to injure. So especially from the lesser trochanter up to 5 centimeters, we need to be very careful. And one more important trick that we do is if we are not in a obese patients where we are not confident of passing the wire passer, if we are afraid of injuring the vessels, we try to fold the wire into two by folding it to two, and then try to contour it into a curved fashion, and then try to pass the finger onto the from the anterior portion, and then try to pass by making the rent in the vastus lateralis septum. You can pass the curved portion of the circularized wire, which is a blunt one, and then try to catch it with finger, or you can use a curved artery forceps and then try to bring it out. That is also we have used many times to be away from vascular injuries.
So the next question is, what is the indication for proximal femoral plating in subtrochanteric fracture?
Primarily,
Yes.
suppose if it is a high subtrochanter, for example, what I mean is high subtrochanter is like at the level of lesser trochanter. Suppose if there is a transverse like a A3 type of fracture, so you can go ahead to do a plate fixation.
And another great indication is the one you saw, very small canal. It's a good indication for plating, short fragment, very small canal that we need to ream a lot to put an 8 nail. It's a good one. And if it's a deformity of the canal. But usually in our practice, we use more for complications, non-unions and osteotomies.
Next question, is there a difference in the entry point for the trochanteric fracture and subtrochanteric fractures?
The entry point is defined by the type of nail you're going to use. For subtroch, you can use the lateral entry point, you can use the tip of trochanter entry point, and you can use the piriformis fossa. So each nail gives you the right entry point. For the tip of trochanter, there is a little bit medialization to avoid varus. So it's just a tip when you use, but in general, the nail defines the entry point that you must follow. It's not the fracture itself.
So, what any tips on positioning on the fracture table, relation of the pillar post to the ischium?
I go simple. I always go in the middle. I don't move the post. It's another problem for me. So I keep the post in the middle, and I move the hip, I move the chest of the patient, and less variables for me to look.
Because if you keep the central post in the center, it is always privileged. Suppose if you move it to the opposite thigh, you are directly putting the pressure on the sciatic nerve. Suppose if there is a delay in surgery, then there can be a sciatic nerve palsy that you need to look. Especially in the obese individuals, you must be very quick. So in those instances, if you want to bring the hip to lateral, you can just use it for some time, but you have to be very quick in those instances, where if your support will be onto the opposite thigh.
If
there
we
any-
use post in the center, there is a possibility of pudendal nerve palsy, sir.
No, but that pudendal nerve palsy that happens is only in a very obese, and then if you have kept it for adduction for very long time, suppose if you have given it for very long time, adducted, and then the traction, high traction you have given, then of course pudendal nerve palsy will happen. But Devendra, only cases we have done, so I don't think it is an issue. You have to be quick. That's it. You have to be quick. You should avoid excessive adduction, excessive traction. You must avoid, and then be careful in obese individuals. You should know. You should not. You have to be very quick in those obese individuals.
Okay.
Follow any thoughts on this?
Well padded. It needs to be well protected. Well padded, protect the soft tissue. Don't just use just the post. Use it well padded, well protected. Perineal and the foot.
So in case of ipsilateral trochanteric fracture with the diaphyseal femur fracture, what is the opinion on single implant?
Trochanteric and shaft.
Yes.
I think it's a good way to go with the nails that we have today. It's a little bit different from the neck and shaft, where the implant for the neck it's going to be difficult, especially on the very proximal ones. When it's a trochanteric and it's very proximal, that we cannot use the retrograde. So today I intend to use the cephalomedullary nail or the new recon nail for one implant.
So Dhanshekar, in the other sense also, like if you take a neck with the shaft fractures, the shaft is always the comminuted one and the neck is always a secondary fracture. So a lot of violence is taken by the shaft one and then the secondary fracture is the neck. So the displacement part of it will be less in a neck fracture. So it is single implant is usually done away in those scenarios. Whereas sometimes you will see that neck is comminuted and also is displaced. In those instances, it is better to use a 2 implant because you have to reduce the neck also well. So in those instances, 2 implants is preferable. That is the way we take it in the institute. So,
Is there any difference in the tip apex distance for a DHS screw versus a blade?
you mean DHS and or
The spiral blade versus screw?
Yeah, it's the same. I don't think there is any difference. You have to follow the same principle of tip apex distance because the whole point is like the last few millimeters is the one that is going to have a good subchondral bone where you can give a purchase to the screw. So where it is going. So that is the best way. It doesn't change. Paulo, you are the lead in that. So
Yeah, they are the same because once it's there, it's the biomechanics of collapsing and avoiding varus that's going to work. I pretty much follow them even with the nail, with blade or screw. What changes is the technique. With the screw, you need to ream, to drill, and insert the screw. It can rotate the fragment, hold it. With the blade, you don't drill all the way down. You just insert the blade to get a better fixation.
So while using a wire around the greater trochanter, one of the surgeons asked that you are passing it through the bone or the abductor mechanism, which is not a very stable fixation. He is suggesting you should pass it around the proximal femoral nail, around the nail.
no, that's what you have to prevent slippage. So because I already told you that the diameter at that level and the next diameter is changing. Suddenly it will change. It will definitely slip down. So either you penetrate, you just make a drill hole and then hold on to the bone, or you have to go through like implant, or you have to hold it somewhere. You have to hold it. It cannot just stay there. So
in a patient with shattered entry point and also comminuted lateral wall, will you still nail it or will you change it to a proximal femoral plate?
Suppose in that scenario, even in that scenario, it is better to do a nailing and then do a tension band wire for that. So I think nail is the better option than other scenarios. That's my take. I think, Paulo, what is your?
I think that's the main difference of the DHS when the lateral wall fails, and the trochanteric with nail when the lateral wall fails, because the nail become the lateral wall. So biomechanically, it's an advantage. So I don't worry too much with the lateral wall comminution and nailing. I just pack everything together.
So if you have a grossly displaced lesser trochanteric fragment, will you circlage it and fix it?
Nope. Just leave it. It's a lot of effort. It's a lot of dissection to get there. And the psoas, it's a strong tendon with muscle. It's a huge force to get it back. And once you fix it, next day it pops out.
I think last year we had one fracture where we fixed the lesser trochanter. If I remember correctly, well, Murugesan must remember that fracture where it was a long segment of medial comminution. So that is why we had to pull it and fix it. But if it is an isolated, like routinely in a trochanter that you see, where it is like an avulsed fragment or a part of it will be with the inferior calcar or down, you don't need to fix it. But that fragment was pretty long, so I had to go and bring it back to position by a circlage wire. Otherwise, there is no need for fixation.
If it's the whole medial wall, start with the neck,
yes,
and come all the way to the shaft, then that's a different scenario.
Yeah, that is what we have fixed.
Yeah. Yeah.
So there's a question from Dr. Pari from Coimbatore. It's PFN. In PFN, is distal locking must for all cases?
Pardon, I didn't hear the last question.
In PFN, is distal locking must for all cases?
In a short nail or long nail?
Probably it means long nail.
And I think if there's a hole, you need to fix it to put a screw in. So I fix all the short nails and all the long nails, I lock it. Rotational control, it doesn't hurt anybody.
Any difference of opinion from other panels? I have no idea.
We also use locked both proximally and distally. We lock it in all cases. But there is a report which said that in a long nail, if it is a stable trochanter fracture, you don't have to do a distal locking.
The guys from Italy, they presented a lot of paper, and I was at the academy, and was Potornetta commenting the papers, and that was such a long list of problems he listed from that paper without any answer, like anterior cortex perforation, long-term follow-up, varus displacement, rotational displacement. And I think that you can't go through so many problems not having the screws there that, in my opinion, just don't justify. If you want one screw, okay, two screw, I think it's better. Allows the patient to walk on the next day and I sleep more comfortable.
So then, Shekhar, I think we are on time, I think. So I think we have to wind it up. So.
Okay, there's still a lot of questions, but we'll continue in the next.
It's going to be the whole day. It's a hot topic.
Anyway, I think there is time is up. I think we have to wind it up. So.
Yes, there are 155 questions. I think 90% we answered.
Yeah, that's good.
Didi, is that possible to watch this on the Ganga video YouTube canal?
Yes.
Later on?
Yes, you can watch. We will upload it into our website. They can anytime they can go and look in.
It's at the website or YouTube canal? Website, Ganga Hospital website.
What are we planning? YouTube?
First we'll launch in YouTube, then we'll subsequently launch in website also.
Yeah.
Okay.
So with that, we come to the end of the session. Any closing remarks from Dr. Deendayalan? We'll close the session.
I thank you all for being here. Number one is, of course, we wanted to make it as a more an educative program. So we will come out with a lot of seminars like this. And also I thank all my colleagues who have taken up their time to be there and present their this thing. Same proximal femur, we are going to come out with second session where we will be discussing the leftover topics in this. So probably in the next month, if Paulo Barbosa is also there, we will invite him again for this seminars. So next month also he can be part of it, but I will let you know the date and the time.
Yep.
So any thoughts on this, Paulo, and what way we can also improve on this? If you give us any thoughts, we can keep it going next time as well. Unmute.
It was a great seminar. It's based on clinical experience, and there's no better way to teach. It's tell you how surgeons do it, the problems and tips and tricks that they have to solve the problems. This is what the audience wants. One thing that could add is a case discussion. The Zoom has many things of polls they can answer on the screens and can get more people involved. Case discussion is always a good thing and can be done easily. Didi, you are mute.
Yeah, you have to unmute.
With the lockdown, from the beginning of the lockdown, we had a lot of case discussions. So it was a case discussion after case discussion. So everything went on. So actually we thought we also be in this forum, we also thought we should finalize a lot of issues that are there in these presentations. So I thought, because one case discussion itself will take a lot of time, and then sometimes we may not get any valid points. So I thought this is one of the best way to teach is also like we can give this. And next time, like when the final session, probably we will add 1 or 2 case discussions that can be done. Yes.
With good educational point.
Okay, thank you all. Thank you all for being with us. So we'll meet you again on next month.
Thank you.
Thank you, Paulo.
Thank you, sir.
Thank you.
Thank you, sir. Take care.
So thank you all. I'm ending the meeting now. Thank you.